Chat box to see.
So we are waiting for Dr. Umesh to join. Once he joins.
Dr. Umesh has a recording, right?
Yes, sir. Yes, sir.
Here.
Or should we have to start or?
So we still have 5 minutes.
We'll wait for 5 minutes.
Vandana is still to join.
Yes, sir. Welcome back, Dr. Vandana.
Thank you.
Welcome, madam. Miss Vandana.
Very good morning, Vandana. Must be really early hours there.
No, late. Late hours.
Welcome, Dr. Pradeep. Good
Thank
morning.
you, sir. Thank you. Very good morning. Very good morning. I'm just adjusting my camera. Share allow. Yeah. Yes, ma'am. Ma'am, we should start.
Yeah, yes, we will be starting. So good morning, everybody. Welcome to the plenary session 14 in the topic of front of package labeling, critical policy measures to address NCD burden in India. Welcome to the session. I welcome the chairperson, Dr. Asim Sanyal and Dr. Ganesh Kumar. It's my immense pleasure to introduce Dr. Asim Sanyal. So, sir is a Chief Operating Officer and Secretary of Consumer Voice, an NGO working in the field of consumer awareness and education, beside other projects on tobacco control, road safety, car safety, environment, health and food, nutrition, and financial literacy. So, he is heading the Consumer Voice since 2007. He has completed MBA from the University of Delhi and he's associated with reputed companies, corporates in India and also in abroad. He has been in this field for around 26 years. So his CV gives us an inspiration to collaborate and to lead or shine forward. So we could see how PA has collaborated with ministries like Consumer Affairs, Finance, Food, Health, Food Processing, Corporation Affairs. And he has also been part of the many standardization bodies and other regulatory bodies, including FSSA. And Mr. Sanyal is also a member of various business forums like CII and others. It's my pleasure to introduce the next chairperson, Dr. Ganesh Kumar. Yes, sir is the additional professor in the Department of PSM Jipmar. And though his CV, he is very simple person, and he told keep my CV to the minimum. And but however, his expertise is very valid and very wide. So he has 16 years of teaching experience, and he has around 160 publications to his credit. And his main areas of interest is mental health and nutrition, and also in maternal and child health. Over to the chairperson. So we'll be sharing the screen.
Thank you, ma'am, for the introduction, and a warm welcome to everybody who has joined in for this particular important session. In fact, we are dealing with a subject which is today gained a lot of importance because of the prevalence of non-communicable diseases as basically a prevalence in the global world, in fact, and India is no exception to that. It is important. Can everybody be muted, please? Thank you so much.
Yes, sir. Yes.
It's an important subject also because this was an unknown field where a lot of work has been going on in the medical fraternity per se, and they have been educating everybody who reach their hospitals or clinics, in fact, but consumers in general had very little knowledge about either cardiovascular diseases or blood pressures or I would say obesity. Many such non-communicable diseases are basically prevalent today, which is of a great concern. And statistics are alarming also because from communicable diseases to non-communicable diseases in the last 2 decades, it's been a paradigm shift in terms of today 67% or 68% of the global fraternity, in fact, is suffering from NCDs, in fact. Now, basically, NCDs have to be tackled as the medical fraternity knows, and everybody knows from various angles. It's important for us to know there is no single dart or single shot to actually take care of the non-communicable diseases. It is a hand-holding exercise between medicine, between consumers, between regulators, between all stakeholders, in fact, including the industry, for ensuring that public health is an important aspect of our life. Now, when I say that there's no single medicine for anything to do with non-communicable diseases, we are basically touching upon an important subject of front-of-pack labeling. Now, front-of-pack labeling basically as a chapter in India started way back in 2014. In fact, since we started talking with the regulator and Ministry of Health, front-of-pack labeling is one of the major measures of bringing in consumers as a stakeholders, because what does the front-of-pack labeling mean? Basically, it means a symbol or a sign telling consumers that this particular food is unhealthy because of either high fat or high sugar or high salt. Trans fat, of course, was earlier there, but then Government of India has taken a very bold measure of eliminating trans fat from January 2022. So these 3 angles basically are major contributors to unhealthy foods. And what is the importance of FOPL as we see globally is basically that this is one thing that makes consumer aware before buying any product, whether it's healthy or unhealthy for him or her or the family. And these symbols basically are of various types, and we have still not decided on that. As a part of the committee working with the Food Safety and Standard Authority of India, I am basically very glad to say that we have overcome most of the challenges associated with the introduction of FOPL. There are two areas which are still being worked on. The one is the symbol, this design. There are various designs which are floating around in the world, and there is no single one particular label which can be called as the best label. What is suited to a particular country or particular region is important for us to adopt, and that's why FSSAI is doing a study through IIM Ahmedabad to come out with a label which is familiar, which will become familiar to all consumers, and they can recognize unhealthy foods. We per se as a group, in fact, we are for a warning label, basically because it's a single shot familiarity in terms of a label which has symbols, no written words, and which indicates that it is high either in salt, sugar, or fat, saturated fat. The second aspect is of obviously nutritional profile model. I think that is something which is very important. The threshold levels are yet to be determined, and we are working with a working group of FSSAI to determine that. Both these factors are matters in progress, and we hope that by the end of this particular year, we'll come to a consensus with all stakeholders and with the ministry and with FSSAI as a regulator, and come out with something which is suited to the Indian context of health. And consumers will play always a very important role because of simple reason that once they know that there is something which is unhealthy, probably they'll try and avoid that or consume that less, in fact. So that is the background of front of pack labeling as one of the ways of tackling non-communicable diseases. Eat right, eat healthy, and stay well, in fact. Thank you very much. Over to you, ma'am.
So thank you, sir. So as mentioned, this is front of package labeling and its influence on various non-communicable diseases and also others. It's an important public health issue. So we have renowned speakers with respect to various topics as mentioned. The nutritional profile of packaged food items and global scenario of this package labels, and how food industries interfere and its lobby towards the contents of these labeled food items, and what as a public health professionals we need to intervene, and what are the policy changes we need to bring about to improve this quality and its awareness and decision making process of consumers. So we have very interesting topics and renowned speakers. So first I welcome Dr. Pankaj Bharadwaj, who is currently the additional professor of community medicine and family medicine, Jodhpur, and he is also fellow of Advanced International Medical Education and Research, Philadelphia, and also he has gone training and fellows in ATTC, International Health, Germany, European Society of Infectious Diseases, Sweden, and Advanced Vaccinology course, and also got trained in a Global Tobacco Control Leadership Program, Johns Hopkins Bloomberg School of Public Health. And also he has more than 100 publications to his credit. So I welcome Dr. Pankaj Bharadwaj. Over to Dr. Pankaj Bharadwaj to deliver the session.
Thank you so much, sir. Thank you, Dr. Ganeshan, for a nice introduction. And I think my half part is actually been covered by Dr. Sanyal. He has set a stage so well. So I would like to share my screen if you allow. Host disabled participant screen sharing, it is coming. So if you can allow sharing of screen, so I'll be able to do that. Yeah. Thank you so much. So what I'll do for the next 5, 7 or 9 minutes, that I'll take you very rapidly to the topic which is given to me in form of what we call as diet as a risk factor for non-communicable disease. Ganesh sir, are my slides visible?
Yes, yes.
Yeah, thank you so much. So I think as Dr. Sanyal has very rightly mentioned that diet is playing a crucial role in non-communicable disease. I'll just add to that, that during this era of COVID-19, it was actually a fact which came out very nicely that diet does play a role in each and every sector. So if we are having healthy diet, that will give us a lot of immunity and that will save us from a lot of problems like communicable disease. But at the same time, if unhealthy diet is there, that will put us to a risk of non-communicable disease. So I'll take you to that rapidly because my other speakers will be talking in elaborated way on FOPL. So some of the questions which we are going to take through this discussion of for 7 or 9 minutes would be on current situation of non-communicable diseases. What are these unhealthy diets actually, and role or possible roles of these unhealthy diets on NCDs. So friends, if we have a look on these data, which is being released every year by the World Health Organization, says that currently NCD is taking a huge, a share of morbidity and mortality in world. It says about 70% of all deaths globally. And unfortunately, the sizable number of those morbidity and mortalities in young population. So there are deaths, there are mortality, but that is a premature death. And add to that, the problem lies that most of these deaths are occurring, or most of these morbidities are occurring in countries like India, where we say that we are actually dealing with problems of malnutrition or undernutrition. And if we ask that, what are the reasons? What would have been the possible reasons for all these deaths due to non-communicable diseases? Then these are substance abuse, physical inactivity, and the one part which we are going to discuss today for this plenary is unhealthy diet. Now, there are, very many data which has been released by different organizations and associations. One such data I would like to take your attention to is by International Diabetic Foundation, which says that in 2017, 73 million diabetic patients were there in India, which was second to China. And we are also hearing from a lot of resources and sources that India is going to be the diabetic capital, and it is already a diabetic capital of the world now. And it is assumed that by 2045, the number is going to be doubled. In 2000, and between these 16 years from 2000 to 2016, there was a 5% increase in premature mortality from diabetes. Now the question arises, what are these unhealthy diets? Because as I said, that healthy diet gives us a lot of protection, a lot of immunity, but what is these unhealthy diets? So usually it is characterized by all these ultra-processed food, which Dr. Sanyal has already mentioned, these sugary drinks, and we have started calling them with the name of HFSS, high fat, salt, sugar. Now, the unfortunate part is that though these foods are high in high fat, salt, and sugar, but at the same time, they also lack the very important component which they make the prudent or proximate principles that they lack essential proteins, vitamins, phytochemicals, minerals, and dietary fibers. And that put us to a negative impact on health if we are consuming it regularly and in high amounts. Indian Academy of Pediatrics has recently come out with a kind of an abbreviation. I think many of us know it well, and some of the speakers are going to use it in their presentation also, that they have started calling it as junks food. And J stands for junk, which is high in fat, saturated trans fat, as Sanyal Saab has mentioned, sugar, salty diet, and ultra-processed diet as per classification of NOVA in the 4th category. And stands for nutritionally inappropriate food, as we say that this is just one factor. Even in homemade food, when it is not properly made, cooked in recycled oil, high in amount in sugar, fat, or salt, that also leads to unhealthy food, caffeinated, colored, carbonated, or sugar-sweetened beverages. So all that adds to a kind of a plethora of unhealthy nutrients. Unfortunately, India is a country which boasts of, or which, have this saying of that Indians are born with a sweet tooth. I think this is one of those countries where we do complementary feeding with meeta, with sugar. So if you look at the kind of a consumption which India or Asia is doing is at the rate of 4% annual growth of sugar, which is double of the rate in world. And India's domestic sugar requirement is touching 30 million tons by year 2020. Have a look on the sugar scale. So I've taken this slide from the sources, which says that if we say that 1 teaspoon is equal to 5 grams of sugar, all these beverages are having, that sizable number of sugar in that. And as somebody mentioned that actually it's the same war which we fought against tobacco. It is as addicted as tobacco. And there are huge studies which are coming up that in vitro and in vivo also, that it is as having this addiction, problem as of tobacco. There was a study which shows that it is as addictive as cocaine. Have a look on kind of a labeling which Sri Lanka is doing and writing that sugar is as addictive as cause of diabetes. If you look at figures like these, the countries like United States, where there is an increased intake of sugar, the adults with obesity, the prevalence and incidence is increasing with leaps and bounds. Now let us come to the second part, which is processed and ultra processed food as per classification 4 of NOVA. The question which Sanyal Saab has raised earlier, that why are we taking these unhealthy diet of food so often? Because of the availability, because the consumers are not aware about it. If you look at the kind of consumption, in 2005, it was only 2 kg. But in 2024, it is assumed, or it is projected to be 8 kilograms. If you look at the ultra processed beverages, it is ranging from 2 liters in 2005 to 10 liters in 2024, and we are very near. So we can understand that how this unhealthy food consumption pattern is increasing because of the availability and consumption of these diets. So what is the health impact, as the topic for me today is? These processed meat, which is supposed to be done because of the reason of preserving them, is having all these processes of salting, curing, fermentation, and smoking. And friends, there is enough evidence available. I have written more than 800 studies on the topic has so far been done, which shows that all these processed meats are the strongest reasons, or one of the associated factors for colorectal cancers, followed by stomach cancer. There are different studies going on in countries like Spanish universities in Navarra, which says that if there is a 4 serving per day of consumption, that would add to a 62% increased risk of death in comparison to those who are having 2 servings per day. They say that for each additional daily serving of ultra processed food, there is an increased risk of death, which is of the order of 18% more. We did have some kind of studies 10 years back in Lucknow also, where we find that the problem is actually there right from the beginning, these school-going children. And when we ask them, how many of them take all these fast foods where, due to easy availability or due to the kind of taste, then it's a sizable number, and significant association has so far been seen. So if you ask us or me to summarize that, what are the studied NCD outcomes? There could be obesity, starting from cardiovascular health diseases, cancers, depression, asthma, wheezing, gastrointestinal frailty, and all cause mortality of cardiovascular and cancer mortality. So what if we have started calling them as critical nutrients of public health concern? So these critical nutrient of public health concerns, WHO, FPO, and all other FAO and all other organizations have started calling that we need to keep them under a kind of a control so that the kind of effect on our health can be reduced. Friends, from here onwards, I think I'll be having just 2 or 3 slides because my other speakers will be speaking on these the regulatory bodies of Codex Alimentaricus commissions, which are currently started working on these food code. And I think these 2 are already available on nutrient declarations and nutrient and health claims. And today we'll be hearing the kind of experience of other countries where the FOPL, or supplementary nutrition information in way of front of package labeling, will be introduced to us as the audience, and the experiences of the other countries where they have really shown some evidence that it really worked. This is the current situation of country. India is witnessing this food packaging revolution. There's a huge market of unhealthy food. And I think that's where Sanyal Saab has also mentioned that FSSAI has taken a note of that and started developing these new labeling and display guidelines. So do we have some evidence? We'll be eager to hear from the other speakers. I've just mentioned in one of the slides that countries like Chile, where it has already been imposed, that when there is a sugar, some kind of effective labeling, there is a reduction of these purchases, which they say in 1 year only 24% reduction, and unhealthy nutrients, the availability as well as acceptance decreased by 7%. So I would summarize and I would end my discussion with this slide that definitely, as we know, that there is no denying a fact that diet has definite role and in the morbidity and mortality due to non-communicable disease. And it's the time that one of the important measures, I'm not saying this is the only measure, but yes, one of the important measure would be the warning label, where they will inform and empower these consumers to make these healthier choices, where they are aware that they will lead to a problem of non-communicable diseases. And I think that will surely decrease the load of non-communicable diseases due to the availability and acceptance or consumption of these unhealthy diet. And that would definitely help the public health in longer run. Thank you so much for a patient hearing. Over to the chairs.
So thank you, Dr. Pankaj, for explaining clearly the disease burden with respect to dietary risk factors, how it influences various diseases, and the importance of this food labeling and its awareness generation. So it is clearly explained out. Thank you very much. So over to Mr. Ashim Enig.
Thank you. I think it was a very, very important presentation in terms of summarizing something that we have been talking about in terms of discussion mode. And it's time for action now, in fact. So we will go over to the next speaker, Dr. Ganesh.
Yes. So over to next speaker, Dr. Umesh Kapil. Please. So Dr. Umesh Kapil is currently President, Epidemiological Foundation of India and Professor, Clinical Epidemiology at Institute of Liver and Biliary Science, New Delhi. He is an alumni of All India Institute of Medical Science, New Delhi, with an experience of over 36 years. He has also got many national awards, mainly Dr. B.C. Srinivasa Foundation Award, Dr. M.K. Sheshadri Award, Dr. P.N. Raju Oration Award. And he has got experience in the field of nutrition. And I welcome on this occasion and to deliver the topic of growing consumption of packaged foods and establishing appropriate nutritional profile model for India. Welcome, sir.
Sir, due to some technical problem, Dr. Umesh is not able to join. We'll be playing the video recording of it.
Okay.
I would like to thank Dr. Pradeep Agrawal and all the organizing committee members for giving opportunity to Epidemiology Foundation of India to be a partner of this national initiative. I would like to mention that all the members of Epidemiology Foundation of India would be happy to share the responsibilities which would be given to them by the organizers of this meeting. Well, I would like to start my presentation by making a very simple request, that since it is an online presentation, so there might be a few difficulties. Kindly bear with me. The topic of my presentation is WHO Nutrient Profile Model for Southeast Asia region. And I'll be taking the next 15 minutes and mentioning about it. The format of my presentation is what is nutrient profiling, what is its utility, what is a WHO nutrient profile model for India, what nutrient cutoffs have been used, what was the methodology adopted for development of a nutrient profile model for our country, and few concluding comments. Well, this is the WHO nutrient profile model technical report series published by WHO Southeast Asia region in 2017, and this provides all the details of the processes involved, how we gone about it, and how we have able to publish it. Now, the primary objective of any nutrient profile model is to help in classifying foods so that they can be utilized for marketing of foods and non-alcoholic beverages to children. This is the essential scientific basis of nutrient profile model. It also helps in assessing or evaluating the foods and beverages, non-alcoholic foods and beverages, if they have elevated level of any of the following. Now, just mark over here that when they talk about the elevated levels, they don't talk about high levels. They're talking about the elevated levels of sodium, free sugar, saturated fats, and total fats. Now, what has been seen that consumption of excess of energy, fats, trans fats, sugar, and salt has been associated with a number of diseases, specifically obesity and other chronic diseases. So we can say that nutrient profiling is a science of classifying or ranking of the foods according to their nutritional composition. It helps in preventing the chronic diseases and promoting health. Now, again, just remember that the WHO nutrient profile model is classifying the foods which are more likely to be the part of healthy diet than which are not likely. So here is what we are trying to do. This entire exercise is through healthy diet which can be consumed by the children or the population. Nutrient profiling also helps in marketing of foods to the children, health and nutrition claims which are being made on the food packages. It also helps in developing labeling logos and symbols for information and education. And in this context, we are talking about the FOPL, but essentially WHO talks about the labeling of symbols and logos on food. Now I'll briefly share with you what was the methodology adopted for developing the nutrient profile model for our country. Now, I must admit that I was associated with this nutrient profile model, which was developed for our country. What we did initially, that WHO Regional Office for Europe developed a nutrient profile model, which was official first publication of WHO on nutrient profile model. So we took the help from this model, how they have gone about it. Then earlier we had the WHO issued guidelines on sugar intake by adults and children. Now this is an important WHO document which was evidence-based, and it talked about one essential recommendation was reduce the intake of free sugar to less than 10% of your total energy intake. When I talk about the total energy intake, it is the recommended dietary allowance. And for Indians, we had considered 2000 kilocalories as the total energy intake. and 10% of this is 200, and 4 gram, 1 kilocalorie is equal to 1 gram of sugar provides 4 kilocalories. That means not more than 40 gram of sugar should be consumed. Similarly, for sodium intake, the WHO recommendation is less than 2 gram, reduce it to 2 gram, which is equal to sodium equivalent to 5 gram per day of salt. Now, this is something important. Third, we had talked about, we took the data scientific evidence from another publication, Diet, Nutrition, and the Prevention of Chronic Disease. This intake, and they talked about that your total calories, 10% should not be more than from the fat, and trans fat should be 1% of the total energy intake. Now, earlier also WHO has made recommendations on marketing of foods and non-alcoholic beverages, and WHO has always said that please undertake responsible marketing to reduce the impact of foods which have high in saturated fats, trans fatty acids, free sugar, and salt. So these are the documents which were considered, the evidence which already been generated and deliberated by WHO was considered for developing the NPM model for our country. We do have another document of WHO, the Guiding Principles and Framework for FOPL, for promoting healthy diets. It just talks about what should be the principles for developing a FOPL. Now, what we did was, coming back to the process or methodology, what we did, we collected about 1,091 packaged foods from different parts of the country, essentially from Delhi, Pune, Bombay, Calcutta, and we went to the stores and then we collected it. And then the nutrient contents of these packaged foods were entered in the Excel sheet. And what we did, because some packaged had the nutrient content 60 grams, some they do 40 grams, some they do it 100 grams, or some they do it each pack contains so much. So we calculated the nutrient contents per 100 gram of product. Now we divided all the what you call packaged foods into 18 categories, like chocolate, cake, savory snacks, yogurt, breakfast cereal, edible ices, beverages, ready-to-eat composite food. These are standard categories of foods which were earlier used, and we used these and put down the total nutrient contents of these foods. And specifically, we entered the total calories, total fat, total sugar, and total sodium present per 100 gram of these packaged foods. This is one example that we had so much of packaged foods available. And honestly speaking, when you collect 1,000, 1,100, 1,000 or 1,100 these packaged foods, who has to consume it? We need only wrappers for our study. So it was not a happy situation for the research team of my department to request all the staff to consume these foods, which was not a good decision. Retrospectively, I feel. Now, sometimes this is a simple example that sometimes they do not mention about the sodium content of the packaged food. Although there is no compulsory or mandatory requirement, but it is being mentioned by a large number of people. Now, when we talk about the nutrient profile model, the main concern what we had was that it should be aligned to the existing national food and and nutrition policies and guidelines. You develop an nutrient profile model, and you find that it's not inconsistent with in consonance with the national guidelines. So what we did, we took the national dietary guidelines of India, which has been recommended by National Institute of Nutrition, Hyderabad, of ICMR, and whatever the recommendation, the edible oil should be, the restrict the salt. So what we did, these guidelines, we considered for developing the nutrient profile model. We also took WHO guidance. Okay, the WHO has given us, shown you the earlier documents, and Codex guidelines in developing the nutrient profile model. This is a document from NIN, Government of India. Okay, now what we did was that any food which extended which had more than the recommended cutoffs, we classified is as a excessive in a particular nutrient. Say, for example, total fat, saturated fat, total sugar, total sodium, all these things were added, were being classified as the packaged food which has excess of a particular nutrient. Now, how did we define this? What we defined that the sugar threshold should be, the amount of sugar should be less than 10% of total caloric intake. And we, as I mentioned to you earlier, it was 2000 kilocalories, 200 kilocalories, 10%. That is about 50 grams of sugar. 1 gram of sugar provides 4 kilocalories. For sweetened beverages like colas and others, we put down a threshold of 5%. It should not be more than 5%. Otherwise, we call it a food which is unhealthy or likely to be unhealthy. Total fat content we talked about. If we have total calories of 2000, divide by 9, because this 1 gram of fat provides 9 kilocalories. So our total consumption should be 22 grams if you're taking it from the packaged foods. Now, sodium threshold, again, we talk about the common salt. And again, what we said that it is WHO recommendation also that our food, what we are consuming, should not have more than 1 milligram of sodium per kilocalories consumed. This is important. If a food is providing, if a packaged food is providing 200 kilocalories or 300 kilocalories, that means the sodium content should not be more than, say, 300 milligram. For 300 kilocalories, 300 milligram. So this is important. Now, subsequent to that, we have tested this model in 5 Southeast Asian countries, and it's a field tested. And we try to look at whether this model works or not, what are the deficiencies in it. And we had the regional meeting of all the representatives, including of India. And we had feedback from each of the countries. And then we finalized the nutrient profile model for the Southeast Asian countries. And this is the model which was developed and finalized and printed, and now it is being circulated. Those of you who are interested in understanding more of how the process was done, how we calculated it, how other countries have been following, they can go through this document. It is available on the net. And Dr. Pradeep Agrawal, I would request that he can also share it with all the members. Well, with this, I thank for your patient listening, and thank you, Dr. Pradeep, for giving us this opportunity. Thanks a lot.
So thank you, Professor Umesh Kapil, elaborately explaining the WHO and Indian dietary guidelines with respect to the level of various nutrients, mainly fat, sugar, and sodium levels, and how it influences the health system, and what are the requirements to improve the consumer forum, how it is influencing. So it is very clearly explained. Thank you, sir. I think Professor Umesh Kapil is there online now.
No, the sir is not there.
Not there.
We can-
Okay, thank you, sir, very much. We can go to next session. So next session, I welcome Ms. Vandana Shah, Regional Director, South Asia Programs for Campaigns for Tobacco-Free Kids and its Global Health Advocacy Incubator. Formerly, she was Executive Director of North Carolina Health and Wellness Trust Fund. She worked closely with the North Carolina Governor's Office as an advisor on health issues. She also worked as an Associate Attorney General at the Attorney General's Office for reviewing and approving sales, leases, and conversions of non-profit entities in North Carolina. She also worked on the BCBS-NC conversion legislation, as well as federal managed care and privacy-related legal issues. She is also co-founder of Kiran, a domestic violence for South Asians in North Carolina. She is currently the Vice Chair of the Board of Foundation for Health Leadership and Innovation. So I welcome on this occasion to deliver the talk on global status of front of package labels and food industry interference. So welcome, madam. Over to Ms. Vandana Shah.
Thank you so much to Iphacon for this invitation, and to the esteemed chairs. So I hope you can see my screen.
Yes, ma'am.
Okay. So during my presentation, I'm going to just quickly talk about global trends in front of package labeling and some of the common arguments that industry uses against sort of pushing back against FOPL in general and sort of effective labeling in particular. So I think, we've heard from all of these experts about, the sort of both the growing crisis of ultra processed foods and the urgent need for, informing consumers about which foods are high in sugar, sodium, and saturated fat. And which is why we really desperately need FOPL to put the power back in the hand of the consumers so that they can make an informed choice when they are buying packaged foods. So we've got two major categories of FOPL now in the world. One is interpretive, which actually provides you some judgment. So they're basically they're cut off. So as Dr. Umesh Kapil was saying, that based on sort of cutoff or criteria, there is some judgment whether this food is high in or good or bad. And sort of the examples of this are traffic lights, health claims, warning labels, as well as Health Star and Nutri-Choice. And then you have reductive, where there's really no judgment. It's just a listing of information. For example, this is the dietary daily allowance, and this is like GDA. So it doesn't really give you a judgment on whether this is good or bad. So in terms of the summary indicator systems, you've got basically the star-based system. So for example, right now in India, there is a strong consideration of the star-based system, Nutri-Score, there's health logos and traffic lights. The challenge with most of these sort of summary indicator system is a lot of times they're mixing up various criteria of both being high in salt, sugar, and fat, but also combining sort of other criteria. If you have, for example, other sort of healthy ingredients like, for example, in the star system, it sort of gives you a higher star rating, even if you're very high in, say, sugar and salt, if you have sort of excess fiber or you have flaxseed. So there's sort of some mixed information where the focus is not on indicating high in salt, sugar, and fat. So in terms of there's sort of now wide global support amongst sort of experts as well as WHO for the interpretative FOPL system, because what we look at is interpretive health FOPL system actually provides like clear signals to consumers and helps promotes healthy diets. The WHO Commission on Ending Childhood Obesity has also sort of clearly established that this is sort of really critical for nutrition literacy, and so has sort of the UN Special Rapporteur on the right to health. So I think one point to really emphasize, because there's some question and pushback from the industry in India, is about doing something voluntary. And we just want to say the bottom line is that voluntary labels do not really work. And so we now have FOPL as sort of a most critical and effective emerging policy on mandatory labels. And the whole idea for FOPL to be effective is that it needs to be mandatory. So these are the countries, as you can see from the map, nearly 11 countries around the world. And it's actually, my map isn't updated to show Colombia, which has just adopted front of package labeling in the last 6 weeks. But we have all of these countries around the world. And as you can see, we have 4 countries in Latin America which have implemented warning labels, which are the octagonal, very simple to understand, black and white labels known as the warning label style. So this particular octagonal style, has shown that this is both leads to significant reductions in the consumption of sugar, calorie, and sodium content of food and beverage. It is also really closely associated with the actual reformulation by industry. So just to emphasize, there's 2 real measures of whether a label is effective. And the first one is whether it informs consumers and sort of creates changes in their behavior, in their buying pattern. And the second sort of key measure is whether or not the label is actually resulting in reformulation, because as consumers will move away from product with 2 or 3 of these octagons, which are showing that the product is high in saturated fat, sodium, or calories, we obviously want to see corresponding behavior from the industry in terms of reformulation. And as was shared by an earlier speaker, the Chilean model has shown sort of drastic reductions, in sort of these high sugar salt consumption. The other sort of major sort of kind of label is the traffic light versus the high in. And so there have been 2 major experimental studies that showing that consumers' processing time of traffic light label took a lot longer. And they actually sort of were confused and sort of they clearly were not sure whether the traffic light with the colors of red, yellow, and green sort of confused them. And there was not very clear whether or not they could buy a product because if it had a red, a yellow, and a green. And so basically there are studies now coming out, especially from Brazil, where these comparative studies were done, which clearly showed that the high-end label actually clearly improved consumers' ability to identify healthier products. It would also increase consumers' intention to purchase healthier products. Similarly, another sort of system is the Nutri-Score system, which is also similar to the Health Star system. And that system also did not really allow consumers to clearly and quickly identify products that contain excessive amounts of critical nutrients. And that is the HFSS nutrients, So basically, that's sort of the real challenge, that there's some confusion now, especially coming out from industry, where they are pushing like labels like Nutri-Score and Health Star. But it is very important to mention that these labels do not really give clear information on sort of the 4 key ingredients, that is on total fat, saturated fat, sodium, and sugars. And that's very critical. In India, luckily, we've now banned trans fat. So the proposed label will really need to convey high in sugar, salt, and total fat. And both Nutri-Score and Health Star, all of the studies show, does not clearly indicate high levels in these three critical ingredients. It also conflates other sort of ingredients, and also the red, yellow, and green colors can be confusing, or the stars can be very high for a product, even though it may be high in salt and sugar. So just very quickly, this is what, this is the label that Chile chose. And this is how the label sort of appears. It has to be 10% of the product. As you can see that the box of cereal is very clearly indicated with two labels where it's probably high in sugar and fat. So basically, one of the studies, besides the multiple studies conducted in Chile, and one of the studies conducted by UNC showed like focus groups of mothers to understand the behaviors and the impact of these labels. And we saw clear evidence that not only the mother's behaviors changed, but there was also a change in social norms, because there was a corresponding campaign amongst children related to the octagonal warning. And clearly now even children had begun to sort of recognize that these black logos on any product means it is a harmful product, and that they should not buy it, and the mother should not be packing these snacks. And this is from a 5-year-old in the study. So basically, we find that all of these various Chilean evaluation results, there are sort of impacts on kids' knowledge, on product reformulation, as well as sort of the purchases. So you have a complete marketplace and behavioral shift. So the bottom line is this octagonal sort of shaped label, which shows clear sort of high in sugar, saturated fat, sodium, is what is sort of coming out as sort of the best practice based on both Chile, Brazil, and sort of the other countries in Latin America that have adopted this label. So in my last couple of minutes, I just want to quickly talk about the fact that, in some ways, every country where FOPL has been adopted, the global food industry as well as the local food industry has used a lot of the same arguments. So even though when in India we're looking at these arguments, these appear unique, they're actually coming out of a global playbook. So one of the most, common arguments is that FOPL is not an effective solution to public health problem, because, and I think it's sort of contradictory on its very face, because the industry in every country is investing a huge amount of resources in fighting FOPL, especially effective FOPL. And they want it not to be mandatory, but they want it to be voluntary. They want a weak and effective label. So I think that very much speaks for itself that industry understands that FOPL will lead to decreased purchases of unhealthy item, and it will increase the perceptions and understanding of what is healthy and to reformulation. So FOPL has the ability to really impact the marketplace. But FOPL also is not just a silver bullet. It should be part of a complementary package of policies. But clearly, it is a very effective policy and industry knows it. Secondly, industry, and this is very similar to the claim made for tobacco, that individuals should make personal choices about what they eat, and they're responsible for their own health. And one of the pushbacks is that back of pack nutrition labels, are hard to understand, high in, but we clearly see that once again, individuals are not able to read back in pack labels. They're not able to read just dietary limits. Even a nutritionist, unless they spend 5 minutes, cannot. And we see that people are spending less than 6 to 10 seconds in looking at these labels. So the labels need to be very intuitive, very simple, at sort of a really low education denominator. And in India, we also need to make it sort of something that you can understand irrespective of language. So similarly, we want to show that, high in warning labels are very simple and can clearly make people understand what is, unhealthy, and it's sort of a clear indication. The other thing, industry is heavily pushing in a lot of countries is traffic lights. And as I've shared earlier, it's not effective, it confuses and does not result in changes in behavior. The other very big claim that they push back on and they want a very long period or do not want to implement it is that they say that FOPL would be costly and time consuming to implement. However, you've seen that companies are very willing to rapidly change their packaging when it suits them. We've sort of conducted a COVID case study, and we found that companies globally, including in India, have redesigned their packaging to include COVID-specific messages. And we've seen that they've done this overnight practically. So clearly, companies have the ability to do this, if directed by the law or to suit their business interest. So I just want to sum up that, some of the key arguments that show up both in the legal arena, because there are a lot of lawsuits filed against FOPL, is, that the objective of the measure does not align with the public health goal. FOPL is more trade restrictive, and that FOPL does not align with Codex, and the effect of an FOPL could be discriminatory or protectionist, and it may, infringe trademark rights. I want to say that, country over, none of these lawsuits or challenges have prevailed. And I think where India stands at sort of a really critical measure, not just for India to implement a very effective FOPL, but also globally, because, India would be the largest country to actually adopt and implement, an FOPL, and this would have sort of a huge ripple effect on the world. So I think we're all looking so that India can, adopt an effective label with the CRO standard cutoff, and clearly the effective label that's coming out of studies globally, and we hope will be validated in the Indian studies, is the high-in warning labels. So thank you so much for this opportunity, and I turn it back to you.
Thank you, madam, for explaining detail regarding various types of labels and the case studies from various countries and how consumer purchasing will be decided based on the types of the label, whether it is healthy or unhealthy. Thank you, madam, very much. So I now invite the next speaker, Dr. Pradeep Agarwal, who is currently working as Associate Professor in the Department of Community Medicine, AIMS, Rishikesh. He is also the active member of IPHA, and he is the main organizer of this event mainly. So I welcome Dr. Pradeep Agarwal to deliver talk on call to action to public health professionals for strong front of package labeling in India.
Thank you very much, sir. My slides are visible?
Yes, yes.
Okay. First of all, thank you to all the esteemed speakers nationally and internationally for bringing up the call for action to FOPL in India, and the respected chairs for giving their valuable times for this particular plenary session. We are thankful to Iphacon also for allowing us for this plenary session. I won't take much of a time. We are already on time. So I'll just go with one slide. Why there is a call for action right now needed for FOPL. As it is evident, India contributes to more than 50% of the non-communicable diseases throughout the world. And currently it is being seen as a felt need to adopt a regulatory policies, as being evident from the scientific literature, and my previous speakers have already talked about that there should be a promotion of healthy eating habits so that non-communicable diseases can be addressed on a long-term basis. For this, a call for action for conversion of back package labeling to front package labeling that is more intuitive, understandable, and make a consumer an informed choice. That is the most important component, at least Indian scenario. So usually it has been seen an individual takes just 7 seconds to make a final decision whether to purchase a product or not. So that 7 seconds basically needs to be so informative so that a wise decision can be made by a consumer. Lastly, taking up this call for action, All India Institute of Medical Sciences have launched a campaign for a medical voices throughout India by inclusion of All India Institute of Medical Sciences along with Institute of National Importance like JIPMER, PGI Chandigarh, and other institutions of national importance from a government and a private sectors, so that we all together can collaborate and can mobilize medical voices at individual level, institutional level, and especially with the public health professional associations like Indian Public Health Association as a partner for this call to action. So that is all from my end. Back to the organizers. Thank you once again.
So, thank you, Dr. Pradeep, for launching this special campaign in AIMS Rishikesh and explaining the activities in your institution. And also, we need to expand it, as you mentioned correctly, in other institutions also. Thank you very much. So now,
Coming in here, Dr. Ganesh, I would like to thank all the speakers today who have taken out their valuable time, in fact, and I would like to re-emphasize on the fact that what Dr. Umesh Kapil said, the nutrition profile model, it basically is the heart and the lung of the entire FOPL system, in fact. So a weak system introduction is going to harm more than basically benefit India, in fact. So it's been a long journey for us in terms of negotiating with all the stakeholders in India for a strong FOPL. But I must add here that the medical voices are critical for us because you bring with you knowledge-based science, which is very important for us to convince the regulators and the opposition that we have enough evidence-based documents, in fact. So this participation was specifically important for consumer organizations, basically because we are on the verge of completion of the regulatory framework within this particular year, in fact, and whatever voices reach the right sources, in fact, will make a huge difference to us as activists for bringing in a strong FOPL, in fact. So that is something which all these webinars and workshops are very, very important for us. The takeaway is basically having the right voices speaking up for a strong FOPL system, in fact. Thank you.
okay, any other questions from chat box? Chat box, nothing, no questions.
No, sir, no questions are there in the
No
chat
questions
box.
are- okay.
When saw the live streaming, no questions are there.
So only one point I want to ask to Madam Vandana, Madam. So how we can involve, Madam, these various stakeholders to improve the quality of these interventions with respect to identification, awareness, and practice of this front of package labeling system in India. How we can involve the various stakeholders and how we can strengthen it.
So thank you. That's a really great question because, I wish, COVID has really sort of limited our ability to make it sort of a mass, campaign. Because, in the case of countries like Brazil, we actually literally had labeling tents all over the country, in major cities. We would have obviously, if Iphacon was live, we would have had a labeling tent. So, all of these labels that I was displaying, we would have actually people, do sort of testing instantly. But I think one of the things that we're doing with, as Ashim mentioned, with webinars here with all of the public health professionals in India, or we've been doing events, with various sort of sectors, the medical community, nutritionists, we have sort of other groups coming in. I think the more sort of education and outreach, that we can do with various groups, and if they can write to FSSAI, whether, now there's a lot of engagement on social media, we have surveys, campaigns going on, where, because this is not just something that, the government can decide in the dark of the night, with input just from industry or a few experts. It is something that is going to have far-reaching impact for the health of the country and for the health of the common man. So I think all of them should try to, provide input, whether on social media. And I think there are ongoing campaigns from various associations they can plug into to the regulator.
Okay, thank you, madam. So we need to strengthen, as suggested by the panel, we need to improve the system of this front of package labeling and its usefulness with respect to research for identification by the public health professionals through research, by awareness among consumers, and also to what extent they practice. Consumers, to what extent they practice with respect to their decision making, whether the packaged food item, whether that is healthy or not, and how it influences the various health issues like obesity or others, non-communicable diseases like hypertension. We need to strengthen the research to what extent it affects the health outcomes, obesity and others. So then we can definitely tell to what extent this food labeling will affect by the evidence. So we have to strengthen that. So with that background, sir, Ashin sir, whether we need to add anything?
No, I think we have completed the journey for this particular session, in fact, and all the salient features have been covered by all the speakers. Thanking all of them, in fact, and over to you, ma'am.
Thank you, one and all. Thank you.
Thank you, all the speakers and the chairperson. Now we'll be going to the next plenary session. Over to the next team.
Hello. 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 Hello.
Sir, can you give me a minute, sir? We are just sharing the Good afternoon. Welcome to the next plenary session plenary 16, on the topic of occupational health and safety. It takes immense pleasure to introduce the chairperson for this session. The first chairperson will be Dr. K.C. Premarajan, who is a professor in the Department of Preventive and Social Medicine, JIPMA, Puducherry. Sir has around 33 years of experience. It's honored to introduce my teacher and my guide who has mentored me throughout the whole course. Sir has multiple contributions in the field of public health. He has been a statistical reviewer in Indian Journal of Dermatology, Venereology and Nephrology, and also reviewers in multiple journals, including Indian Journal of Pharmacology and Physiology. He was a management consultant in 100 eye hospitals all over India and in Nepal. And he has worked in various international agencies in the field of eye care. He has been a national faculty in NPCB training program in 1994 to 1998. Sir has a keen interest in maternal and child health, pediatric health and mental health, and also a very keen interest in occupational and environmental health. Over to you, sir. Over to you, sir.
Thank you. So welcome to this session on occupational health and safety. We have a galaxy of experts who have varied experience in the field of occupational health and safety. So it's my real pleasure to chair this session. So we have the first speaker, Dr. P.C. Ghosh, who is going to speak on physiology of work, its relevance to occupational health. Dr. Ghosh has again is a varied experience, especially related to physiology and ergonomics. And he worked in initially at the Defense Science Service Center, and then almost 48 years experience in research, teaching, training, consultancy, especially in ergonomics in various parts of the country. One of his significant contributions has been here to create occupational health center in many industries, and he has produced many occupational physicians in our country. He has number of awards and fellowship, and yes, one of his main contribution has been on developing physiology relating to ergonomics. Okay, he was awarded Government of India Fellowship in Foreign Training and Research, both short and long term. Visited many countries for conference, official duties as Government of India representative. So let me invite Dr. Ghosh to deliver his session. So we'll be sharing the session too. Dr. Ghosh. Can virtual partner share the session?
Good afternoon to all. The physiology of work, its relevance to occupational health is very important parameter in occupational health. Now, conventional physiology, this particular lecture is actually, I prepared it for only professional. Student may find it a little bit difficult because they're not. Okay. The physiology of work is a relevance to the occupational health. This is my topic, and it has been made especially for professional. And student may find it a little difficult to understand this complex physiological process, which has not been included in MBBS syllabus. So, but they can ask any questions, any clarifications during the process of deliberation or afterward. Now, what is the physiology of work? if you see what is the physiology of work, when man is involved with physical work, either for bread, pleasure, whatsoever may be, when he is physically involved, his physiological of human is changed. Systematic study of such physiological parameters on human is known as work physiology, also known as physiology of work. Now you can see here, this is the actual working situation. This is a relaxation. The 7 types of relaxations are there. This is a creative relaxation, postural relaxation, emotional relaxation, and social relaxation, society relaxation, and mental and physical relaxation. So this is the example of emotional relaxation, and this is the directly involving of the human being in physical work, and that is how his physiological parameters are changed. And systematic study of such change of physiological parameter are known as physiology of work. How does it happen? What are the work physiology preferred parameter? It is very important to study the various physiological parameters systematically so that their trained action relationship can be used for industrial operations, such as work physiologists prefer cheap, reliable, field useful parameter. What are the cheap, reliable, field use parameter? Heart rate, rates per minute, oxygen consumption, liters per minute, energy expenditure, kilocalorie per minute, body temperature, degree centigrade. So these are the very easily field-oriented parameter which work physiologists prefer. If you want a controversy, if you want a medical legal complication, in that case you have to go for complicated parameter such as electrocardiography, electroencephalography, electromyography, seen galvanic response, and nerve conduction velocity. So these are the very expensive parameter, require special facility, which is very difficult to practice in shop floor. That is why these parameters are not very much popular. These parameters are very much popular. So this is the concept of work physiology and its preference physiological parameter. What was the benefit of studying all such parameter? This can be used as a job classification through physiology. All industrial operation that can be classified in the form of very low, low, moderate, high, very high, and extremely high. So these are 5 categories. These are 5 categories. You can categorize the all industrial operation in terms of physiological parameter, such as oxygen uptake in liters per minute, pulmonary ventilation in liters per minute, heart pulse rate, beats per minute, and rectal temperature in degree centigrade. So if you study any industrial process and if you find oxygen uptake is 0.25 to 0.3 liters, pulmonary ventilation 6 to 7 liters, heart rate is 60 to 70 beats per minute, rectal temperature 37.5, then this job will be very low category job. And if you go to any other industry and if you find it is 2.5 to 4 liter, pulmonary ventilation 60 to 100 liter, heart rate is more than 75 beats per minute, rectal temperature is more than 39 degrees centigrade. So this is called extremely high job. So very low to low, moderate, high, very high, and extremely high. So this is the assessment. You can do it based on physiological parameter. The safe limit of industrial operation, if you wanted to arrive, you have to see where your people are fitting. So we found from our research, the safe limit lies moderate to high, that is in this range. So all industrial operation, if you can maintain it moderate to high, at that occasional highs are allowed, then you would be able to sustain the job for 8 hours without undue physiological fatigue and without having any safe risk for to operate the work for 8 hour schedule. That is the concept CLI has given for nation, and we have see it in the next. Acceptable workload, the concept given by for India as 8 hour work schedule for static and dynamic work. For dynamic work, it is 35% of your VO2 max, or it should be equivalent to 4.2 kilocalories of energy per minute, or your heart rate should not beat more than 110 beats per minute. So this is the amount of dynamic work you'll be able to sustain for 8 hours if you limit your oxygen consumption at 35% of your VO2 max. So this concept we have given for India. And similarly, if you go for static muscular, it is 33% of your maximum force generated in the muscle, or 3 minutes, whichever is RDR. So this is the example of the static muscular work. This is the example of the dynamic muscular work. So in this case, safe limit is 33%. In this case, safe limit is 35%. So by making the combination of static and dynamic, you can restrict your performance capacity optimum, and so that neither industry is loser nor you are losing your health over due to heavy physiological fatigue. So that is the purpose to design the acceptable workload for India, and this concept we have given from Central Labour Institute, Mumbai, for Indian industrial worker for 8 hours work schedule. Calculation of rest allowances. It is a very, very important parameter. Whenever a person is working beyond his safe limit, physiological fatigue develops. So to overcome this physiological fatigue, certain amount of rest is prescribed, and it is prescribed very arbitrarily in industry, depending on the work study team. And we found it is very, very erroneous. In some cases, physiological fatigue is very high. So very simple device we have developed. And with this, you can calculate the amount of rest allowances. Rest allowances, W multiplied by B minus S divided by B minus 0.03. So W is the length of working period in minutes or hour. B is the oxygen uptake you have to measure on the shop floor. And S is the standard oxygen uptake for continuous work. And for India, it has been decided for 4 kilocalorie per minute. So this is the simple formula we have developed. And based on this, you can calculate the rest allowances accurately in the shop floor. And this is the big milestone for industrial health, that how rest allowances can be calculated. And we have made the ready-made chart. So if your heart rate is 110 beats, you are not entitled for any rest allowances. If it is 140, you are 200% rest allowances. If it is more than 200 beats per minute, your rest allowances will be 300% and above. So this is how the rest allowances is given, and it is always calculated percentage of working time. If you are working for 1 minute, 200% rest allowance means you should give him 2 minute rest. So 20 minute rest. If you are working for 9 minutes, you should give him 27 minutes. So that is how it is always expressed in terms of percentage of working time, and rest allowances is a costly affair. So that is why unless industry come forward, you cannot apply. But fortunately, we have applied to the All Steel Authority of India. Today, all their top men, they are enjoying 300% rest allowance, because no other possible scientific solutions is available. And right now, that is why it has been only as an alternative accepted as a rest allowance. daily exposure to thermal limit in industrial operation. That's a very important area. Environmental physiology is a very big area in occupational health. In many industrial operations, energy compensations is the prime concern of setting thermal limit of industrial operation. In country like India, it is of paramount importance for safety, health, and productivity as we are in tropical region. So we have found out if your consumption of energy is 400 kilocalorie per hour, your operating temperature should be 26 to 28 degrees CET, corrected effective temperature. And if you have a benefit of 50% relative humidity, it can go up to 30.5 to 33 degrees centigrade. If your energy expenditure is 250 kilocalorie per hour, your it is a moderately heavy work, your operating temperature can go up to 29 to 31 degree effective temperature. And if it with the relative humidity, it can go up to 34 to 37 degrees centigrade. And if you are going for a sedentary nature of work of 100 kilocalorie per minute, 100 kilocalorie per hour, and in that case, you can go up to 33 to 35% of your 33 to 35 degrees centigrade. And with a 50% benefit of relativity, you can go 40 to 44 degrees centigrade. So thermal limit exposure we have set for India by studying an extensive research in Vidarbha region of Maharashtra, which is a most highly heated area. And we have come to a conclusion 29 degrees CET is the maximum thermal exposure a person can be exposed in hot for 8 hours work schedule, provided his energy consumption is near 400 kilocalorie per minute. So like this way, thermal exposure have been set very clearly. And because of this thermal exposure, people will be able to work for further. Ergonomics function industry. Most of the people, they know the Ramazan 1633 to 1714, founder of occupational industrial medicine. It's very true. But how did he found industrial medicine? Studied the occupational diseases, advocate the workplace inspection, necessary tool for discovering causes of the disease, for preventing diseases, encourage the eventual passage of factory safety and workman compensation laws. In 1700, he wrote Worker Disease in Latin, describing the health hazard of receptive motion, posture, irritating chemicals, dust, metals, and other and abusive agents for workplace in 52 occupations. So that is how actually he came in this. Ergonomics Foundation was actually filled here, Safe Workman Compensation Act, by visiting the workplace. A doctor should visit the workplace. That is the suggestion Professor Ramjani has given in 1630 to 1714, very old concept, and today it has become refined. That is how ergonomics came in the foundation stone. What is ergonomics? A tool for industrial health and its definition. It is a science of human biology and engineering defined by ILO. It is a United States, it is known as human factor research. And in Scandinavian country, it's known as the environmental research Scandinavian country. So different country, ergonomics has a different name, but everybody's idea is to see that man is safe, comfortable, and healthy at shop floor without having undue physiological fatigue. That is the base concept. And factor affecting the human in shop floor, physiological factors, psychological factors, environmental factors. In environmental factor, heat, cold, illumination, noise, and vibration. So these are the factors which affect the human being. All this factor either has to be controlled or it has to be eliminated from the shop floor so that man will be very, very comfortable at shop floor. If you see the definition, it is the science of human biology and engineering. So this is the biological science. This is the engineering science, different branch of specialty of engineers, different branch of specialty of biologists. So they form together group, and that is called ergonomics. That is how ergonomics came to exist in shop floor to improve the safety, health, and productivity of worker. So that is the main reason the ergonomics become very popular in shop floor, to improve the safety, health, and productivity with a proven laboratory experiment. So that is the main concept of ergonomics in shop floor. Now, how ergonomics can be useful to benefit to industry as well as community and increase productivity. Ergonomics always helps to increase productivity by reducing accidental rate, by improving health status of workforce, by reducing musculoskeletal disorder among the worker, by reducing occupational back pain and shop floor. So these are the beneficial factor if you practice ergonomics in shop floor. And we have seen this is the simple factor, back pain, which doctors do not have any control. And because of that, 20% of productive time in every industry they lose every day. If you take care of back pain, you can save 20% of your productivity at your endurance time. And this endurance time will increase your productivity. That is how ergonomics helps us to increase the productivity, reduce the accident rate, improve the health status of workforce, reduce the musculoskeletal disorder, reduce the occupational back pain. The postural stress, a challenge to industry, person as well as community. Postural stress can be evaluated in two simple techniques. One is called ruler. Ruler is called rapid upper limb assessment. It's a very simple technique which you have to do it in the shop floor. And action limit of ruler is up to 7 scale. 1 to 2, it is negligible, no action is required. 3 to 4, the low risk change may be needed. 5 to 6, medium risk, further investigate, change soon. And if it is more than 7, very high risk, implement change immediately. So this is how action limit, ruler action limit guide you what you should do, what you should not do. Similarly, another technique, level of MSD risk by REBA. REBA is called Rapid Entire Body Assessment. So REBA will help you to understand the total physiological fatigue due to bad posture by scoring the score 1 to 11. So if you can see here, all the scoring level, if it is 1, it is negligible, no action is required. If it is 2 to 3, low risk, change may be needed. 4 to 7, medium risk, may be further investigated. And 8 to 10, the high risk, cannot be continued. And 11, no further, immediate change. So this is how postural stress can be evaluated in shop floor in a very objective way, not in a subjective way. It is an objective way, and it can be taken. Action limit would guide you what you should do, what you should not do. Advantage and the good posture. That's very important. Advantage of the good posture is it increases your memory and learning, makes you look powerful, and reduce the back and neck pain, improve your mood, improve your breathing, increase your testosterone, makes you taller and slimmer. And disadvantages, constant fatigue, depressed, increased risk of Alzheimer's, increased fat tissue, increased risk of erectile dysfunction and low libido, and increased risk of osteoporosis. So this is the advantage and disadvantage of good posture. So which is very important. We get more advantage if we maintain our posture good. We enjoy the better health status if we enjoy our posture better. The psychological well-being a must for industrial as well as community and alternatives names of ergonomics. So industrial occupational psychology is the branch of psychology that applies the principles of psychology to the workplace. The purpose of this industrial occupational psychology to enhance the dignity, performance of human beings and the organization they work in by advancing the science and knowledge of human behavior. Recent development of industrial occupational psychology, human factor engineering, human engineering, engineering psychology, applied experimental psychology, occupational psychology. So these are all, and this is the different factor. You are made of psycho and physio, and this is the intuitive. You have an intuition so that you can design something. You have a problem solver, you can solve the, you are flexible, you are analytical, people to person, and empathetics. So these are the human character, and based on this behavioral character, human factor engineering, human engineering, industrial psychology, applied experimental psychology, occupational psychology, these are all developed. You see the physiology as a continuous takes the total care of industrial and community health. Definition of health by WHO. The promotion of maintenance of highest degree of physical and mental and social well-being of worker in all occupation. Thus, it covers the man as a total human being who will be enjoying the benefit of fruits of his labor. So you can see here physical work, mental work, social well-being, all this if you take care of it, the man and woman, they enjoy the benefit of their labor at the end of 8 hours work schedule when they go back to their house. So ergonomics and work physiology, their main intention is to see that 8 hours work schedules at shop floor is maintained safe, productive, and healthy. Thank you very much. If you have any questions.
Thank you, sir. That was a very informative presentation on work physiology. And you have correctly highlighted the principle behind the ergonomics and the benefits of understanding the physiology to improve the workers' safety, workers' productivity, and more important is definitely preventing the accidents in our industry. Thank you, sir. Now we move to the next presenter, that is Dr. Shyam Pingle, who will be speaking on occupational diseases prevention and control. Dr. Pingle is an occupational specialist and adjunct professor at Indian Institute of Public Health, and he has more than 40 years experience in practice and teaching, and he has received number of recognition awards on occupational health, corporate health, population health. He is member of various committees and International Commission on Occupational Health, and he is also a national president of Indian Association of Occupational during the pre-2009-11, and also worked in various industries. He was vice president Reliance Industry, and he is awarded the ADM oration, CK oration, L&D oration, and he has number of publications to his credit. And so now I invite Dr. Pingle to make his presentation. Virtual partner, please share the presentation. Dr. Pingle.
Very good morning to all the delegates. At the beginning, I would like to thank the organizers and IPHA in particular for including occupational health in the plenary session. So thank you very much. This is how we will go ahead over next 10 to 12 minutes. Whenever I start speaking on occupational health, these 4 principles are a must. I always like to enumerate them and share with my audience. So we know that every human being has an occupation. It's not that only those who go to an industry or those who go to a mine or those who do some physical strenuous work will have an occupation. Each one of us has an occupation. All the delegates here have an occupation, and even I have an occupation. Even a child has an occupation, and even a retired person has an occupation. That follows the second principle, that is every occupation has occupational hazards. There is no occupation which does not have hazards. And all these occupational hazards, if not checked, will develop into occupational diseases which have no cure. Barring some toxic emergencies, there is no cure for occupational diseases once they develop. And the silver lining is that all occupational hazards can be prevented. Therefore, we must aim at preventing all occupational hazards and all occupational diseases. If you look at the burden of occupational diseases, you'll find that almost 65% of Indian population is in working age, and we spend more than 1/3 of our life in hazardous workplace environment. The occupational health coverage in developing countries is minuscule, but even in developed countries, it is not very high. So because it's a neglected specialty. We always see that this ILO figure, because Indian figures are not yet available, so we will have to make do with some ILO figures and some modeling. More than 2 million people die each year from work-related diseases. And there are people who are dying from occupational diseases. Then there are non-fatal occupational diseases. They say every 15 seconds a worker dies from a work-related accident or a disease. And every 15 seconds, 153 workers have a work-related accident. These were the figures in 2013. Now the figures are likely to have increased. If you look at the Indian figures, which are available through modeling, not through Indian data, you can see that the total occupational mortality in India is about close to 4 lakh. That means more than 4 lakh people were dying in 2011. Now the numbers would be even higher. Now, why occupational and industrial health? It's not only the people who are dying and people who are suffering, but we are also losing a lot of GDP because of this. They say that 4% loss of GDP is because of occupational and safety factors. And in developing and emerging countries like India, the loss is up to the extent of 10%, which is even higher. What we see today in the occupational safety and health trends, there is a massive migration of people and therefore migration of hazards also. The informal work and small sector is increasing. There were traditional diseases already, but new diseases are getting added. The female working population is increasing. Stress and lifestyle diseases are emerging occupational health issues. Now, since last 1 or 2 years has come, the work from home and also gig working, they are adding different elements. These are the major known occupational health problems in our country, but this is not a complete list. These are only the important ones. Now, the something very important about occupational diseases is cause is not very easy to see, and you are not able to identify or relate the disease with the cause. If you see now, this is the x-axis, the time, and the y-axis is whether you can identify the cause. You can see in case of accidents, you can identify the cause very easily. In musculoskeletal disorders, it is difficult, and in case of lung cancer and leukemia, the cause cannot be identified very easily, whether it is noise-induced hearing loss, because it takes a long time to develop. And that is where we come to this principle: what the mind does not know, the eyes do not see. So in occupational health, we want to always aim at early detection of disease, very early detection when the disease may be reversible. This epidemiological triad, you all know very well. You are all public health experts of agent, host, and environment, how it affects the occupational diseases also. These are the occupational hazards: chemical, physical, biological, ergonomic, psychosocial. I'm not going into the details of it for paucity of time. Now, when we want to prevent the occupational hazards, this triangle, inverted triangle, you must remember. This gives you the steps as well as the hierarchy of controls, what are most important and most effective. So elimination, when you physically remove the hazard, is most important preventive measure. When you cannot remove the hazard, you should replace the hazard, that is by substitution. When you cannot do this, we can have engineering controls wherein we isolate the people from the hazard, and then we can also have administrative controls wherein we can change the way people work by changing their work practices as well as giving some additional features which prevent their exposure. And the personal protective equipment which protect the worker, such as use of mask, use of earplugs, muffs, and other things. Now remember, these PPEs, which are most commonly used, are the least effective, and therefore they are the lowest in the hierarchy of controls. And what is most important is elimination and substitution. So we have to remember that. So there are various types of monitoring: environmental monitoring, exposure assessment, biological monitoring, medical surveillance. And when we look at elements of occupational health services at the workplace, these four things are important: assessment and control of work environment, general preventive health measures like giving immunizations, improving their awareness, giving them more knowledge, preventive medical examinations like pre-employment medical examination, periodic medical examination, pre-retirement medical examination. Then we also have a pre-placement medical examination, which is a baseline medical examination whenever any new work starts. And then medical treatment. Why these medical examinations are important? Because we can detect the disease early, and if we detect one disease case, then we know that there may be more cases, there may be other cases which we have to look at the workplace, and we have to prevent the spread of the disease. So these are the various measures: administrative, engineering, ergonomics, and medical measures. These measures are used to prevent occupational diseases. Administrative measures could be like scheduling of production, scheduling of tasks, scheduling of duties, job rotation, and other measures to minimize exposure. Remember, they are only temporary measures. Administrative measures are temporary measures, and we should never ever stop at them. Engineering measures are important, and they can be done at various places, not only organized workplaces, but also at smaller workplaces also. So substitute the harmful agents, enclosure, isolation. Whenever there is a drilling, we can use a wet method so that dust generation is not there. Good housekeeping, protective equipment, various safety precautions, and of course, environmental monitoring. Monitoring of workplace environment is very, very essential. We have to monitor workplace environment, and we have to also monitor the worker, which we can call it as personal monitoring. Ergonomics is a very important tool in prevention. I will not go into the details of it because my colleague Dr. Ghosh will talk in details about it. In medical measures, as I have already briefed you, these various medical examinations are important. Pre-employment, periodic. Then we can also have health promotion, health education, and specific protection, just like our principles of preventive health, and assessment of risks by supervising the working environment very closely. Health promotion is another important angle wherein we can have workplace wellness, physical activity, nutrition, weight management, immunization, smoking cessation, awareness and education such as in HIV/AIDS are important. Another thing which is important in prevention is having a healthy workplace wherein we create islands of healthy work. We create islands of healthy people because we have a group of population which is available, which is a cohort, especially at the workplace. Generally, we have a cohort. So we can invest in educating that cohort and promoting the health promoting conditions. And workplace wellness would generally address the health priorities, improve the overall health of employees, provide safe and healthy work environment, design health benefits and health promotion programs, and support the business continuity, which has become very important in COVID times. So once again, before stopping, I would like to repeat these 4 principles. Please remember them and apply them to your work, to your home. Even at home, it is important. Every human being has an occupation. Even the so-called housewife or homemaker is also having an occupation. So please remember that all occupational hazards can be prevented, and that is what we need to do. So with this, I'll stop here so that we can have further presentations and also spend some time on questions and answers. Thank you so much. Thank you, IPHA, once again for giving this opportunity to me and to Occupational Health to figure and feature in your plenary sessions. Thank you.
Thank you, Dr. Pingley, for your very comprehensive presentation. I think especially your stress on control measures, on elimination and focus on environment, and importance of surveillance and workplace wellness. I think if any questions are there, we'll see the chat box, so we'll have it at the end. Now, a request, we'll go to the next presenter. We have Dr. T. Rajagopal, who will be speaking on occupational health for healthcare workers. Dr. Rajagopal is working at Beach Candy Hospital Trust as Chief Operating Officer. Before that, he has worked in Global Medical Occupational Unilever, and he has more than 30 years experience, and he is a governing board member, National Safety Council of India, and alumnus of University of California, School of Public Health. And he was trained at Harvard University on advanced leadership strategies for healthcare executive. And he is member, Safety Health Leadership Team, member of Steering Committee member, and past president of Indian Society of Occupational Health. And he was also editor of Indian Journal of Occupational Health and Environmental Medicine. So he'll be speaking on occupational health for healthcare workers, very important area, which especially during the time of COVID. So over to Dr. Rajagopal, the virtual partner, please share the presentation.
Good afternoon, everyone. At the outset, of course, I would like to thank the Indian Public Health Association for giving me a platform and an opportunity to interact with all colleagues. It's indeed a pleasure to interact with all of you virtually. And today in this session on occupational health, I want to touch on a slightly different subject to what normally one would be speaking about. And that is about the occupational health for healthcare workers. I'm not sure how many of you are actually aware that 2021 is the International Year of Health and Care Workers, and they do need our support and help to keep themselves safe. Now, what exactly are the occupational health hazards in this entire community of healthcare workers? And as this chart shows, it could be a range of hazards from biological to psychological, including bloodborne conditions like hepatitis B and C and HIV, airborne pathogens, impact of radiation, radionuclides, lasers, anesthetic agents, awkward work postures, and stress, shift work, and workplace violence. We should, of course, not forget the non-communicable diseases at the workplace, because just like work can impact health, health can also impact work. Rather than giving the whole range and gamut of what all can happen to healthcare workers, I thought of concentrating on a few specific risks just to introduce this subject. And today I want to speak about a little bit about occupational health risk, which we find in hospitals. The first one is exposure to hazardous drugs at the workplace, at least in pharmaceutical industries and all. Exposure to anesthetic gases at the workplace. Then a little bit on sterilizing agents like glutaraldehyde. And what happens when you do a surgical procedure using electrical cauteries or lasers. And finally, a little bit on burden of non-communicable diseases, which also is work-related stress. Now, about exposure to hazardous drugs at the workplace. Healthcare workers who prepare or administer hazardous drugs, that is those used in cancer therapy, hormone agents, or those who work in areas where drugs are used, may be exposed. I don't have figures for India, but at least in the US, we have 8 million healthcare workers potentially exposed to the hazardous drugs. And these exposures can cause acute and chronic effects such as skin rashes, adverse reproductive outcomes, including congenital malformations, and sometimes even cancers. What are the various jobs which may be involving exposure to hazardous drugs? It could be pharmacists, nurses, physician and physician assistants in hospitals, operating room personnel, veterinarians, and others who ship, transport, or even receive hazardous drugs. If you look at the medical surveillance, especially in the pharmaceutical industry, you need engineering controls, essentially biosafety cabinets, good ventilation system, and you need to have proper environmental sample wherever analytical methods are available to understand the risk and what the people are being exposed to. You need to have a very clear policy of personal protective equipment and double gloves, non-permeable gowns, and other respiratory protection. So the elements of a medical surveillance program for workers exposed to hazardous drugs can include a general and a respiratory questionnaire, which looks at various body organs which could be affected because of exposure to hazardous drugs. And then putting in place engineering controls and other preventive measures, and a plan to provide a basic initial clinical evaluation, including laboratory testing for workers being potentially identified as exposure candidates. Now I go on to the next exposure which healthcare workers can face, and that is very common, especially in hospitals. And these are exposures to anesthetic gases. Who are exposed to these anesthetic gases? They could be anesthesiologists, dentists, operating room nurses, and surgeons. And even for a short while, if you are exposed to a high concentration of anesthetic gas, you could have headache, irritability, fatigue, drowsiness, and liver and kidney disease also. The workers are most likely to be exposed to these gases where there are less ventilation or scavenging systems, or where even in a recovery room where a patient is kept immediately after a surgical operation, the room is not properly vented. So how can hospitals or employers reduce worker exposure to waste and anesthetic gases? So you have to have a proper scavenging system, a good ventilation system with at least 15 air changes per hour, out of which at least a minimum of 3 would be for fresh air, and install a good ventilation system to prevent exposure to the waste anesthetic gases, which is exhaled by the patients. You do need to keep a good record of samples for at least 30 years and obtain baseline liver and kidney data for the operating room personnel prior to their being actually assigned to their job as an anesthetist. In terms of reducing the exposure to anesthetic gases, you have to look at the patient's breathing circuit for negative pressure. You should have to turn on the loom ventilation system, connect the gas outlet to the hospital's central scavenging system, look at the uncuffed endotracheal tubes, use the lowest possible anesthetic gas flow rates for proper functioning of the anesthesia, and do not deliver anesthesia by an open drop method. If a mask is used, make sure that it fits very, very well, and turn the gas off finally before turning off the breathing system. I'm sure these presentations would be available to you at the end of my talk, so therefore I'm not reading every single line on my presentation. I just want to give you a broad overview of occupational health issues for healthcare workers. The third example I wanted to give was exposure to glutaraldehyde in hospitals. This is an agent which is used as a sterilizing agent, cold sterilization of instruments in endoscopy and surgical units. You use it in disinfection of histology and pathology laboratory tabletops, in fixation in histology lab, and in development of X-rays also. So what happens if you are exposed to glutaraldehyde? You can have throat and lung irritation, asthma-like symptoms, nose bleeding, rash contact, headaches, and nausea, as you can see in this chart. So if you have to get protected from glutaraldehyde, you have to use, again, engineering methods like local exhaust ventilation. Keep these baths under a hood which can suck it out wherever possible. Use only that much of glutaraldehyde to perform the required disinfecting procedure. Avoid skin contact, wash your hands, wear goggles and face shield, and attend training classes on safety awareness. Everywhere we recommend you have something which is called as an MSDS, or a material safety data sheet, for any chemical which you use in a hospital setup, so that immediate first aid is known to everybody around that place. Now about the laser and electrical surgical procedures. During surgical procedure, you can actually destroy the tissue by thermal means. And you can see smoke coming out. If you have attended surgical operations, you will know what happens there. So research studies have confirmed that this smoke can actually contain toxic gases and vapors, such as benzene, hydrogen cyanide, formaldehyde, and even live cellular material, including viruses. At high concentrations, it can cause ocular and upper respiratory tract irritation in healthcare personnel. The smoke has unpleasant odor and is also can be mutagenic. So the best way is to have smoke evacuators where you have an inlet nozzle which can suck out the smoke, and the velocity of 100 to 150 feet per minute at the inlet nozzle is generally recommended. You take this out through a system which has a high efficiency particulate air or a HEPA filter, which will filter out all the toxins. Sometimes you don't have a smoke evacuator, but you have only a liquid evacuation system. Now that is not as effective as a smoke evacuator. So therefore, to prevent occupational health issues arising out of laser and electrical surgical procedures, we would strongly recommend the use of smoke evacuators. I don't know how many of you are aware, but recently the WHO and the ILO, they gave a joint estimate of the work-related burden of diseases and injury. I'm just showing a little bit of a snapshot in terms of some of the occupational illnesses which can happen to healthcare workers. One is, of course, the exposure to formaldehyde. Sometimes it leads to nasopharyngeal cancer and leukemia also. So this, I would recommend you to go through this because it gives you the disability adjusted life year for almost all the occupational exposures, not only in the healthcare sector, but even outside it. The second one is occupational asthmagens. Like I told you, many of the anesthetic gases, glutaraldehyde, many of them are capable of inducing asthma. And the most recent one is that if you work for long hours, and this is a bane for healthcare workers because nurses and doctors, especially in the ICUs, they put in even double shifts. Sometimes they even have to work for more than a day till they are relieved. So exposure to long hours is being seen to be a cause of stroke and of ischemic heart disease. The figures are here in terms of the percentage and the DALYs. You can go through it later on, but this is a very serious issue. And finally, when I look at the burden of non-communicable diseases, including mental well-being, these are all the data which is very strongly loaded in favor of the fact that cardiovascular diseases, cancers, respiratory disease, and diabetes are important for almost 80% of the NCD, morbidity, and mortality. In a workplace, for instance, the long hours of work, which I told you before, the stress and strain of working, and recently also we have found that mental depression, anxiety are almost constituting 23 to 40% of issues as far as healthcare professionals are concerned. All this take a toll on doctors, nurses, ward boys, everybody working in the space of healthcare. So we should not forget the impact of non-communicable diseases on the health and well-being of all our people. Essentially, work-related health conditions that cause the most amount of deaths per year are chronic obstructive pulmonary deaths, stroke, and ischemic heart disease. And all of these are prevalent almost in the same proportion in healthcare workers. So how do you prevent and control them? One thing important, of course, is that from the point of view of occupational health, pre-employment and periodic health checks are very important, including biological monitoring wherever it's available to find out who and who cannot work in a particular environment. From the least effective to the most effective ways of controlling, the most effective would be elimination, physically remove the risk factor wherever possible. The next would be substitution, replace a risk factor with a less risky one. Engineering controls, which I spoke to you a lot about, very often used very well in terms of design of operation theaters and design of various hospitals. Then administrative controls of how people work, not to work long hours, shift hours, all these need to be taken into account. And the last one, which is the least effective, is of course the personal protective equipment. In this unfortunate time of COVID, health and care workers are at the forefront of COVID-19 response by providing high quality treatment, and they need absolute support in terms of what they are doing. So we would like to vaccinate all employees against COVID, both the doses. The PPE quality should be absolutely top class with N95 and impermeable overalls. In the ICUs and in the wards, you must have separate donning and doffing rooms where these personal protective equipment can be donned and doffed. We also advocate antibody testing, including virus neutralizing antibodies, to see whether people are still having the antibodies required to be able to fight the virus. The issue of booster doses of COVID vaccine is still under consideration. And finally, I just want to tell you, how do you vaccinate your healthcare workers? This is both the CDC and the IMA recommendation. We have, of course, added COVID vaccination recently, but otherwise, normally this is the range of vaccine which we would like our healthcare workers to be given. It could be hepatitis B, hepatitis A. Then you have tetanus and diphtheria, then varicella, polio, influenza, pneumococcal and meningococcal vaccine, typhoid, MMR, and also rabies. Especially in places where in primary health cares where you've got your people working, you must include rabies as one of the vaccination. In terms of compiling this overall presentation, which I believe is more of a primer towards what happens in the space of healthcare workers and their occupational health hazards, I've had to do a lot of searching around because not much of information is available at one place in terms of what the healthcare worker can suffer from. So I would urge you to go ahead and explore these sources of information, which is NIOSH, CDC, WHO, ILO. I did speak to you about the WHO, ILO joint estimates of work-related burden, and finally the International Federation of Infection Control. As the WHO says, health and care workers are vital to our future, and your voice to those calling for more investments in health and care workers is extremely important. Thank you. And with that, I come to the end of my presentation.
Thank you, Dr. Rajagopal. Your presentation has been a real eye-opener to people like us who work in healthcare field. I'm really glad that you put the health ventilation and of late with advent of technology, hospitals have become very complex environment, complex we should say organization. So I think your presentation is really very useful to all the healthcare workers. Usually we don't give much importance to our safety. We generally neglect that. And I think that point you have very nicely put it up. Thank you, Dr. Rajagopal, for your sharing experience and sparing your valuable time. Thank you. Now we go to the next presenter. We have Dr. R.K. Ilangovan, who is the Director General, DG Firstly, Mumbai. Dr. Ilangovan has been currently working as Director General in the DGFS General Factory Advice Service and Labor Institute. He received his PhD in Industrial Safety and is a mechanical engineer by training. And he is a member of various committees of academic research programs. And he has done a lot of work on occupational safety health, industrial. He is an industrial safety expert. And he is also faculty in the field of occupational health for various renowned institutions, universities, and he is a chairman, member secretary of various technical committees on occupational safety health. So Dr. Ilangovan is going to share his lot of experience on the occupational, especially on promotion of role of DG Firstly in promotion of occupational and safety industries. So I request Dr. Ilangovan to have his presentation. Welcome, Dr. Ilangovan. Please start your presentation. You may share your slides.
Yeah. Good afternoon. First of all, I'd like to thank the organizers for inviting me to be part of this conference and to make a presentation and in between you and lunch. But I request the participants to bear with me so that I can finish it maximum within 15 minutes. See, DG Firstly is under the Ministry of Employment, the Government of India, mandated to work on safety, health, and work environment at workplaces, except mines. So this is the first organization in the country fully dedicated to occupational safety and health under the Government of India, and we continue to lead the movement in the country. And we are the part of the Ministry of Labor and Employment. We are responsible for framing policy and other strategies, including other action program, occupational safety and health. Currently, we are into major issues. One is the Factories Act 1948 and state rules. As we knowing, we are the administrators of the factories and we coordinate the implementation of that with the state governments by framing model rules and also working with them. Also enforce the Dock Worker Safety, Health and Welfare Act 86 Regulation 1990 in the 12 major ports of the country. The organization objective is to see that the safety and health is, seen in, enforced in workplaces, particularly these dog works. We also work on promoting the safety, health, and environment workplace. Of course, conduct public programs, trainings, workshops, studies, and we also advise the ministry as well as take part in the area of occupational safety and health in the international scenario representing India. We also develop legislation, standards, guidelines, COPs, and other related aspects on workplaces. DigiFathli is also of the Prime Minister Shiram Award on behalf of the ministry, as well as we are operating Vishwakarma Rashtriya Puraskar National Safety Award. In fact, it was started way back in 1945 in Delhi, and then it started function Mumbai campus, CLA campus, since February 1966, which was inaugurated by the President of India, Dr. S. Radhakrishnan. And if you look at the, I don't want to take much time because this health is being paid by DigiFathli, our country, and we have FAA's factory, and we have dog safety inspectorate, we have awards, and we have 5 institutes, mainly the Central Level Institute at Mumbai, where DigiFathli. We are also having regional level institutes in Kolkata, Chennai, Faridabad, Kanpur, and we are also developing one new institute at Shillong for the benefit of the North. And government is also planning to go for another institute in Japan. And of course, we have all the 12 major port country. We have exclusive dog safety inspectorate, and they are enforcing the Dog Workers Act and regulations in the major ports. Look at the activities, important activities of DigiFathli. It's almost in synonymous with the ASH movement in the country. 1966 is the year where the CLIs and RLIs were developed. 1986, DigiFathli developed the Dog Workers Act 86, and we have also enforced the regulation. We have drafted the central rules under the BOCWA. We have a lot of activities in terms of supporting the Amendment to this Act, model rules, creating standards. Also part of the central rules, 200 rules on occupational health for the construction industry is being taken care by DigiFathli. In the year 2009, the Government of India has brought a policy on safety, health, and environment at workplace. DigiFathli, the main organization behind developing the policy, a comprehensive policy in line with the Constitution of India. We have also worked and contributed towards the development of Occupational Safety and Working Conditions Code 2030. Many of you might be knowing the government has made 44 labor legislations into 4 codes. One important code, the point of focus of this conference, Safety, Health, and Working Conditions Code. And this code provides a kind of a diverse mechanism, which is much more having far-reaching consequences than the Factories Act. It covers all the trade, all activities, business activities under the code. And the Government of India has formulated 4 committees, particularly for factories, dock works, construction, building construction works, and fire safety, to frame standards under Section of the code. And the factories and dock works are headed by Director General DigiFathli. Of course, construction safety, one Mr. Murthy, VP of L&T is heading, and a fire advisor heading the fire safety. Basically, the purpose of the standards on occupational safety and health is that after the standards are framed and duly vetted by the National Board and by the Ministry of Labor, this will create international standards on occupational safety in the unified country, which is an important activity. We also work with the factory inspectorate, framing model rules, framing guidelines, framing standards on occupational safety. do conduct, the 1-month certificate course for the supervisors handling chemical industries as under Section 41CB of the Factories Act. Our major activities, if you say in terms of academics, in terms of courses, we run 1-year diploma industrial safety course, which is a must under the Factories Act for a qualified safety officer in all our institutes. Iphacon is also conducting 3 months associate fellow of industrial health course, which is for the occupational health practicing personnel, which is a mandatory requirement under the current factories rules as well as the standards which are going to be framed. The occupational health experts should complete this course to declare them as a factory medical officer or construction medical officer or any type of legal position. As I told you, we also train the inspectors, the factory inspectors on occupational safety and health. And you can see the data on the accidents in our country. In fact, this is the data published by Iphacon by collecting with the state governments. You can see there's a constant decline in terms of non-fatal injuries. And of course, there is a fluctuation in terms of fatal accidents. But you can see the entire trend is happening despite increasing the number of factories, the number of workers employed in there. We have also done a survey for silicosis prone industries in support of the state governments as per the Honorable Supreme Court order. We have almost covered all the state. We have visited about 5,433 factories, and silicosis prone factory 2,472 had been covered by Iphacon, and we have almost covered 1,59,940 workers, and we have identified almost 616 silicosis cases during the survey. We also publish a standard reference note. This is an important document. This is the documented, validated data on OSH at workplaces, of course, except mines, published by Iphacon, which is available in our website, Iphacon website. And this will be an important document for the researchers or any policy planners to understand the OSH movement in the country. We have entered MOU with various organizations. Currently, the MOU with DGUV of Germany is being operated on occupational safety now. We have organized a lot of online programs on food safety, chemical safety, and other related issues. The Government of India, as I told you, is organizing 3 awards. Of course, these awards are under consideration, but the Prime Minister Shram Award is the highest award given to an employee who does exceptional contribution, record performance, devotion to duty of high order, specific contribution to productivity. And there are 33 awards under the scheme. This is given by the Honorable Prime Minister of India. And you can see these are the categories. The one award is the Shram Ratna, which is equivalent to Bharat Ratna and other categories. Shram Bhujan and Shram Veer, Shram Virangana, Shram Devi and Shram Shri. We also operate Vishwakarma Rashtriya Puraskar Award, and this award, if you look, is operated from 1965, and this the objective used to again recognize the worker who contributes it, and the award is applicable to factories and docks of the construction site. We have 28 awards under the scheme. These are the categories, Class A, Pratham Shreni, and Class B, Dvitiya Shreni, Class C, Tritiya Shreni. And we also give annually National Safety Award. Again, it started way back in 1965. It is given to the industries establishment to recognize their safety performance. This is based on the frequency rate of accidents and accident-free period, considering it with the national average. And 248 awards are given by 1 winner and 1 runner. And of course, these are the schemes. These awards are given annually, and the current year, last year award, because this is for the calendar year, the 2020 award application is still through. I would request the industries who are part of the program to actively participate in the award schemes of the Government of India so that you can get benefited out of it. And the Dog Safety Division of Iphacon, as I told you, we enforce the dog workers' safety, health, and welfare in the major port. We also look into the isolated storages in the ports. We take care of the chemical safety, occupational health issues with respect to chemicals management. We look into in terms of the unclaimed hazardous cargo and processing activities inside the port area, including the disaster management, on-site emergency planning, safety audit, and so on. So this is the data of accidents in the major ports of the country. You can see it varies from 8 to 17. The numbers are, even though they are very less, most of the accidents are contributed to road safety and with respect to metal handling. And these are the institutes we have. Basically, all these institutes we have created a basic 3 divisions. One is industrial safety, industrial hygiene, and industrial medicine. This is the occupational health. These are the 3 divisions which are available in all the institutes of DG Fasting. Of course, in the Central Labour Institute, Mumbai, we have staff training, productivity, major hazard and chemical safety, and work environment engineering division. We do conduct training programs, seminars, workshops, studies by these divisions, and particularly the industrial medicine division is looking into the maintenance of occupational health, and then we also work on prevention and treatment of diseases, accidents, and injuries. We do conduct in-plant and public programs in the field of industrial medicine. We conduct studies, surveys. In fact, currently we are planning to go for we are doing a study on textile industries, occupational health aspects, including safety aspects in textile industries, textile workers. We have completed a study in asbestos industries in terms of occupational health and safety. I've also asked my directors in my department to work on doing a study on occupational diseases and their prevalence, prevention, and control, and occupational health management system in our country. We have exclusively training and productivity division where we train the people. We look into training programs and designing the program, and also connect occupational safety and health with productivity. All of you would agree with me. Safety, health, environment at workplace, productivity, all should go together for a better workplace. So we have an exclusive division on major action hazard, which was created after the Bhopal gas disaster with the support of ILO. So coordinating on MH-related issues and working with the state governments and the MH factories in managing, preventing, controlling disasters, accidents. We have created an exclusive division, work environment engineering division, which is to look in terms of, doing studies and related to noise, vibration, radiation, and heat stress and pressure. In the month of June 10th, we have also created a new division, DG-3, Construction Advice Service Division, which is dedicated to construction industries, and we are also taking up activities. After the COVID-19, like many organizations, we also look into conducting online training programs. So far, we have done about 171 training programs. And, of course, we covered almost 4,644 participants, covering 2,005 organizations through our online training program. We have fixed a very minimum fees of 250 rupees per participant so that, the interested person can participate and take active part in this program. These programs also covers occupational health. We are part of G20 ASH Experts Network, and 2019 we have developed a national ASH profile for the country with the support of ILO. We are also a part of the central rules and other model rules under the code and this thing. We also look in terms of the expert committees rules and all that. We have started publishing the industry news, which is half-yearly newsletter from the last year. You can see it, it's in a website. We upload it. Now we have made it once in 6 months issue. And we bring out a lot of technical reporting in this magazine. I would request the organization experts to contribute their papers for publication in the public domain so that, we spread the awareness on occupational safety and health. We have created webinar facilities in all the institutes. That's very important. So we would like to network the industries. And very important point is that we should network industries, institutes, and organizations connected to occupational safety net. So we are open to have more joint ventures, programs, studies, research studies in the field of occupational health and safety. We have taken up a drive to update our safety and health welfare centers, IV laboratories, and industrial medicine laboratories. And we have taken up as I told you, a lot of national and regional studies on occupational safety and health. I would welcome experts to come forward if have anything to suggest. And I keep the options open for the experts and industries, institutes. We can jointly work on occupational safety and health, because there are so many issues when it comes to occupational health, sector specific and region specific, organization specific aspects we need to cover when it comes to occupational safety of the country. I just am open to having interactions with the institutes who work in the field, where we can work on joint programs, studies, and so on. Not last but not the least, the occupational health still has to go a long way in our workplaces. In fact, the current standards we are bringing, the roles, duties, functions of the factory medical officers, will also bring them for the construction medical officer. We'll also, we should work more on the creating medical criteria as under the national policy for the occupational diseases, which is yet to be resolved. And that should be a kind of joint exercise to create medical criteria for occupational diseases. And we should also work them towards providing them under the standards of the country. With this, I would like to thank the organizers for inviting me. My special thanks to Mr. P. Ghosh, my good friend and senior, who have been constantly driving me to be part of this program. And of course, Vishnu Priya also. I thank everyone for inviting. Thank you for your patient listening. Thank you very much.
Yeah. Thank you, Dr. Ilangovan, for sharing your experience and especially highlighting the organization setup in our country for framing the policies and how to enforcing the occupational safety. It's really, you are very comprehensively presented the initiatives and the organization available in our country. And also you focused on the course training, the various courses offered. And it's been very heartening to see that when you shared the data related to occupational injuries, though, as you said, the number of factories have increased, the work complexity has increased, still you are able to at least maintain, at least control the number of fatal injuries. I think that speaks about the various training program and various safety precautions you are enforcing in their country. So I think there is with this, we have covered all the presentation, but if we have one question, I think for Dr. Rajagopal from Anurag, that is, how do we reduce the stress and musculoskeletal problems in a healthcare work setup? Dr. Rajagopal,
yeah, that's a very timely sort of a question in terms of what is afflicting not only healthcare workers but everyone. Roughly 1 in 4 people suffer from either depression or anxiety. That's the latest statistics as far as mental well-being goes. And this is higher probably amongst the medical officers and the healthcare workers. And in terms of musculoskeletal, it's all to do with bad posture. For musculoskeletal disorders, I would urge people to adopt the ILO checklist on ergonomic standards. In fact, there's a whole treatise, a book by the ILO, at the end of which they give this checklist. It's a set of questions which you can apply at the workforce. And I think that's very, very good in terms of understanding where you can have work-related injuries because of musculoskeletal problems, bad postures and all. Do that, and it has got some training tips also in terms of how you can control them. Low-cost measures to prevent musculoskeletal disorders at the workplace. That's one. Okay. For healthcare workers suffering from mental well-being issues, what we normally do is that we train people in mental health first aid. This is different from normal first aid, which other doctors and paramedical staff are used to. In a workplace setting, the supervisor or the leader is trained to recognize of symptoms which will suggest to you that this is an early beginning of an anxiety or depression in terms of an employee not concentrating or not having a good relationship with fellow workers and all. So there's a huge checklist which can be followed, and there's a training for mental well-being. There are standardized stress questionnaires available which can tell you the degree of stress and all. But the most important thing is that to recognize mental well-being not as a stigmatized event, but as something which can happen like any other non-communicable diseases, and allow people to take time off. Classical examples have been in the recent Olympics and even in the recent tennis thing. The people have just taken time off saying that, look, I can't take this anymore. And the slogan which you normally use is that it is okay not to be okay. That means you recognize that you can have mental health problems, you can have trouble with your co-workers and all. It's all a question of how do you recognize and how are you trained to do it. The most important thing is training, and again, more training to identify these signs and symptoms and support people.
Right.
Psychological counseling is very important. And
Yeah.
finally, you might want to refer a person to a psychiatrist. There's no taboo in that, because all of these are chemical imbalances in the mind. Yeah, it's nothing to do with anything else. You can set them right. So these are the efforts.
Okay. Thank you, sir. That's input. So finally, any of the other panel members who have to share any points, you're welcome.
Yeah, I would just like to add to the excellent answer given by Dr. Rajgopal already. He has explained how to address them. But we'll have to apply the same principles. First of all, early detection, as Dr. Rajgopal has explained, has to be there at all the places. But we also need to introduce this workplace stress right from the medical education. Right when the student is in final MBBS, he has to understand that he has entered into an occupation, a vocation, which is going to have stress. So stress resilience is very important, how to cope with the stress. Because it's impossible, it's virtually impossible to stop stress from all the factors. Some things we can control, but there are many things which we cannot control. So therefore, we doctors have to become resilient, and we need to have coping mechanisms, how to cope with the stress where it comes. So these are the things which also need to be, in addition to what has been already said, stressed upon. Thank you.
Okay, thank you. I think for paucity of time, I think let me conclude this session by thanking all of Dr. Ghosh, Dr. Pinkley, Dr. Rajgopal, and Dr. Nagovan for sharing your valuable time experience. I'm sure this will be a real eye-opener and very useful to all the delegates who are attending this IPHA conference. Thank you once again for everyone. Thank you. Let me conclude this session. Thank you.
Thank you.
Yeah, welcome.
Good afternoon. Can you hear me, Dr. Biju? Can you just confirm that you hear?
Yes, sir, we can hear you.
Yeah, thank you, Dr. Biju. So we welcome all the delegates and our chairpersons and the speakers for the 18th plenary that we are conducting as a part of the 65th IPHACon 2021. The title of today's plenary is Role of Health Technology Assessment in India, Evidence to Policy. I'm very thankful to some of my friends who have agreed at the last moment to do this plenary for us, because we thought any public health conference cannot end without, having a discussion on evidence to policy. And who better than the DHR team, our HTA-IN initiative that has been launched by the ICMR, and a group of people who are working behind the scenes should also be given that platform to educate the young minds about what is the role of evidence and what are the how do we look at the cost effectiveness issues? How do we take decision? How do we take what are the points to be considered before recommending something to the policymakers? So I'm really thankful and grateful to all the dignitaries who have joined today. Let me tell you that there are 1,500 delegates who have registered for this conference, and we had the theme of the conference was public health more than ever now. And in that we have 3 sessions, 3 sub-themes. The first day, the theme was on, effect of COVID-19 on health systems. Then the day 2, it was on public health action. And in day 3, it was on capacity building to handle subsequent pandemics and as a capacity building as a whole of the public health community. In that, this HTA or health technology assessment in India, what role it plays and how can we proceed further is the theme that we are trying to discuss in this particular event. So with this background, let me introduce the chairpersons for today's session and Dr. Muralidhar. Doctor, I'm not seeing sir in the, can anybody see? Dr. Sankar, can you confirm sir is there?
No, I don't see him right now. But
okay. Maybe sir can join in due course of time. We'll start in the interest of time. We should start on the session on time. So it's my great pleasure to introduce Dr. Biju Soman, a very dear friend and professor at Achita Menon Center. With 20 years of teaching experience, contributed immensely for data analytics in public health informatics, GIS in public health, telemedicine, health and health technology assessment. Around 24 publications for his credit. Very humble CV that you have given us, Dr. Biju. We know about you. So, anyway, thank you so much for agreeing to be a part of this and joining us from Trivandrum. We have 3 distinguished speakers here. Dr. Kavita Rajsekhar, if I can say, she is the backbone of all the activities that we conduct in this country. Thank you so much, Dr. Kavita, for agreeing and sparing your valuable time on a Sunday to talk about the role of journey of HTIN in India and educate our young minds, the public health students and MD medicine, MD community medicine residents. Will also benefit from your deliberation. And Dr. Sankar Prinja, another, what can I say about him? The star and ever glowing star. And so nice to have you, Dr. Sankar, over here. He will be talking about using HT evidence, but we look forward to your session. Finally, Dr. Beena Joshi, thank you so much, ma'am, for joining us. It was lovely to have you here. So in all our plenaries, we try to have a mixture, the gender equity to be reflected. So nonetheless, your work speaks for itself, ma'am. So thank you so much and welcome to this plenary. Now I hand over the session to Dr. Biju. Once Dr. Muralidharan joins in the due course of time, maybe we can continue that. Over to you, Dr. Biju.
Thank you, Dr. Sudhanshu. And first of all, let me thank the organizers of IPHA, especially Dr. Sudhanshu and the team for including this very pertinent topic in the paper. And this is very, very important when we are heading for universal health coverage. Many new technologies, new interventions are coming up. And India being a federal state, actually, we had to see what all things can be included in the common kitty, that kitty of healthcare services that is being provided by the government. And for that, health technology assessment is very, very important. So before government decide upon to take that particular intervention, be it a vaccine or new treatment or new program, we have to look at the aptness of that program and what will be its impact on our budget, and what will be its impact on the societal perspective beforehand. For that, we need to build capacity in our country to see that, because this health technology assessment basically is a multidisciplinary initiative. And for that, we need competent groups of people who will be able to take up this task in a timely manner. So that is the very importance of health technology assessment. And for the postgraduate students in community medicine and public health, let me assure you that this is a new area where you can look for a very prospective, very encouraging career. And because although when we are starting a bit late in India, we have to learn from the experience of other countries. At the same time, the issues of India are very unique, and we have to come up with our solutions and all. So I'm very happy to co-chair this session with Dr. Muralidharan, who is one of the doyens of health economics in our country. And they have, I think Dr. Sudhanshu has handpicked people to give these deliberations. First of all, let me invite Dr. Kavita Rajashekar. Madam is, as Dr. Sudhanshu said, she is the key person who is coordinating the entire health technology assessment in our country. And she holds a PhD in biochemistry and molecular biology, but for long she's working in this area of policy health technology assessment in ICMR. And she coordinates the health technology assessment program and working actively in the implementation of HTA. And not only in the implementation of HTA, under her leadership, a series of training programs is being launched, not only for academics, but also for health system persons in the country. So very good initiative, ma'am. And she is part of the core team that worked for enhancing COVID-19 testing facility in our country. Of course, as a pivotal person in ICMR, she is looking after many other things, including assisted reproductive technology regulation bill and the health technology assessment bill, which is almost through the cabinet approval. And probably she will be giving us a overview on the health technology assessment India initiatives and where we stand now. Over to you, ma'am.
Thank you so much for an elaborate introduction. And it's a nice platform to share it with family HTA people. So Sudhanshu, Dr. Shankar, Dr. Beena, Dr. Biju Soman, it is really nice to have this. Can I share my screen?
Yes, ma'am, you can share your screen.
Is it visible?
It's visible now. Yes, ma'am, it's visible now.
Yeah. So shall I start?
Sure, ma'am.
Yeah. So given this opportunity to talk on the journey of HTA in India, it's a privilege. And the journey started with when the government was committed to extend the healthcare services to the population as a part of the universal health coverage. The Economic Survey 2020-21 also recommended that should be an increase in healthcare services from 1 to at least 3% GDP. They also said that we should reduce the out-of-pocket expenditure to about 35%. The implementation of Ayushman Bharat as a health insurance program, which covers about 5 lakhs to over 100 million vulnerable families, also requires optimal utilization of the resources. This can all be ensured by HTA was the tagline with which the journey started. I think all of them should be knowing what HTA is going to do. It is a tool for assessing optimal utilization of the existing resources, which by providing affordable and accessible healthcare for the population of India. So we look into the clinical effectiveness, the cost effectiveness, the safety, equity, ethical, and the budget impact which is involved in implementation of a program, of a technology, of a screening program. It could be a drug, it could be a device, and so on. So HTA evidence can support use of healthcare technologies in the form of medicines, diagnostic devices, medical devices, programmatic interventions, surgical interventions, guidelines, standard treatment guidelines, and health benefit packages. The need for HTA was also felt by the 119th Parliamentary Standing Committee report, which said that we should have a centralized health technology agency, which is going to assess every technology that is going to be implemented. This was further supported by the National Health Policy, which said we should have a central health technology assessment body. With all these things, in April 2017, HTIN was established under Department of Health Research, Ministry of Health and Family Welfare. Recently, a working group of ministers on health was being established, and they were constituted. They identified and recommended that the Central Health Technology Assessment Agency should be established, and it should be functioning with the Ministry of Health and Family Welfare, supporting all the new interventions. The objectives with which HTIN was being established and constituted was to undertake HTA studies, to support the process of decision making with evidence-based background, to develop systems to assess new and existing health technologies, to apprise the data with the available cost, clinical effectiveness, and safety of all the health interventions and technologies, to analyze evidences in a systematic, reproducible way to ensure accessibility, disseminate research findings so that this can be populated into policy decisions. The structure of HTIN, when we established it, it had the highest body, which was the Medical Technology Assessment Board. It also has technical appraisal committees who will evaluate the HTA studies. Technical partners and resource centers were established as extended arms of the Secretariat, which was in-house, constituted in the Department of Health Research. The process that we follow, we do not take up any topic on our own. Topics are provided by state and the central government. Then we prioritize the topics on the availability of evidence that is there. Then partners are identified, proposals are developed. The appraisal is taken for the evaluation of the technical appraisal committee. Once the proposal is being approved, it is taken up for the study. The completed study is brought back to the technical appraisal committee. In between this, all stakeholders, they could be industry partners, partners who are there in the state who are implementers, the medical association bodies which are there, part of the health or the medical policy making bodies are taken into consideration. Approval is also given for the evidence by the highest body, that is the Medical Technology Assessment Board. Then it goes to the central and the state government for implementation. How do we prioritize a topic? So we look into any topic. It could be a technology, it could be a drug, it could be a program. We look into what is the population size that is affected by that particular intervention, the disease severity, potential therapeutic benefits that it is going to give to the system, economic impact on every household expenditure, availability and relevance of the evidence when it is going to be implemented. How is it going to be prioritized by the health policy interventions and health policy makers? The methodological framework, I think Dr. Shankar and Dr. Beena would be explaining it with every single study that they have taken up, and every single study that has been taken up by the resource centers. We look into the costing, we look into the effectiveness, we look into the cost effectiveness, the equity, financial risk protection, and the landscape analysis. What are the achievements of HTIN in the last 3.5 years? So we have about 17 resource centers and 10 technical partners who have been established geographically across all the states and across the central, east, west, north, and south part of the country. We have 20 studies completed and documented into policies, but there were also smaller studies which have been completed and which helped in supporting procurement decisions, which helped in supporting point of care facilities that could be part of health and wellness centers. 43 studies are ongoing. We had 24 technical appraisal committee meetings, board meetings, stakeholder meetings. Capacity building workshops are a part and parcel of HTIN to increase the capacity of all the technical centers that have been established. We also have 26 state nodal officers who have been appointed. The biggest national costing study on the healthcare system, which supports the revision of prior PMJAY packages, was being rolled out, and the last 3 years they have completed the first phase of studies and including district hospitals. So this is a platform of all the studies that we have completed. There are about 33 studies here. We supported during the pandemic, we supported with the low cost portable ventilators. We have medical devices which have supported in implementation across the country, health programs which have helped in revision of screening programs in Tamil Nadu, Gujarat, Andhra Pradesh, and so on. Diagnostic devices like TrueNat, which was even repurposed during the COVID time. Guidelines like the Eurocall guidelines, which provided the utility set of values for India. The budget impact analysis guidelines, drugs, the long-acting reversible contraceptives. Then we had surgical interventions, which have become a part of the standard treatment guidelines, point-of-care facilities, and the health benefit packages, which were supported by the National Costing Study, the biggest costing study initiated in 16 states of India. These were some of the manuals that we developed during the course of our journey. We said we should have a process manual which we follow, and we revised it in 2021. We have an HTIN methods manual which has an ISSN number, has been documented into a book. We have policy briefs. All the 20 policy briefs have been documented into a book. We have the costing manual which was being prepared by PGI Chandigarh. We have the first phase of the CHSI study that has been documented, and the EQ5D study that is being documented, with a booklet which documents all the HTIN achievements till date. What are the evidences that have supported the decision making in some of the healthcare sectors across the country? This I have brought in to identify how states are also responding to the HTIN evidence that has been supported by the center. The safety engineered syringes, which was a study that was being done by PGI Chandigarh. Punjab issued instructions to use of safety engineered syringes. Andhra Pradesh issued a GO. It was implemented as a part of the national hepatitis guidelines. Delhi was also asked to follow a similar protocol and a policy documentation that was done by Andhra Pradesh and Punjab. So this was some policy documentation, how it helped in policy making by other states. This success story followed. The intraocular lens for cataract surgery, this was used in the package revision for the National Program for Controlled Blindness. Our strategy for cervical cancer screening was used in the strategy for cervical cancer screening by the program of NCDCD. So this has been documented and implemented by the central government. Evaluation of pulse oximeter, which was done for the state of Kerala. They procured pulse oximeter in all the primary health centers, which were repurposed during the COVID time to support pneumonia patients. Portable automated auditory response for neonatal screening have been procured by Tamil Nadu, Telangana, Punjab, and even private hospitals are being rolled out after a HTA was done for this particular device. Hemoglobinometers. We did a validation study also and a HTA study also. The technical specifications have gone into the Health and Wellness Center technical specifications for the digital hemoglobinometers after an HTA was being done by the HTIN Center also. Continued again, we said TrueNat. We did a cost effectiveness analysis to identify this as a diagnostic tool for TB for the National Tuberculosis Research Program being implemented by the Health Ministry. This was being endorsed by WHO. It was repurposed during the COVID time. Similar study was also done for the diagnosis of influenza, an Inventrogen kit, which was being recommended and has been procured in many parts of the country. The health technology assessment on low-cost portable ventilators, they were procured during the pandemic time, and this was a study that was being initiated in coordination with AIIMS Delhi. A lot of COVID-supported things, we did life cost analysis for high-throughput machines, for next-generation sequencers, RT-PCR cost. They all helped in procurement of all these kits and machines during the COVID time. Success story continues. We said the largest study that we did on cost health analysis costing study, which was being initiated by PGI Chandigarh. The first phase we completed. We helped in the revision of the health benefit packages during its journey from 1.0 to 2.0, and the journey continues when we are revising the packages from 2.0 to 3.0. We have our HTIN ICMR website, which gives all these details. a data repository for all the raw data. An app also we have developed and it is under construction. This will be rolled out so that state government will be able to fill in their data in the portal. The National Health System Costing Database, which is being developed by PGI Chandigarh, will have all the databases of the costing study included in it, which will be an eye-opener for many of the states to identify what could be the cost of any packages that they would like to revise or revisit. Now, the journey continues. We thought now it should become into a legislative document. We said Health Technology Assessment Board Bill has been drafted, which proposes to constitute a board to provide HTA system that evaluates all the safety, clinical effectiveness, and economic costing to promote universal health coverage. This will institutionalize the HTA structure, reduce the out-of-pocket expenditure, promote equity. Now, this bill has been drafted, the cabinet note, along with the committee for establishment expenditure, which will be due course moved to the cabinet for its approval. With our journey of HTIN, we would like HTA to impact in the prioritizing and identifying interventions that can be included in government schemes, increase the budget allocations so that we will be able to increase the healthcare allocations in the coming years. We should be able to provide the cost of health benefit packages and a uniform cost for the whole country. Life cost analysis can be done for all the diagnostic and medical equipments that can be procured. Cost of drugs that can be used and identified for its cost effectiveness and implemented. Point of care diagnostic facilities can be rolled out in primary healthcare centers. Advanced diagnosis can be provided. Cost effectiveness treatment strategies for reducing maternal and neonatal mortality can be spread on. AI-based technologies should be provided. With this implementation, new programs can also be implemented for enhancing the quality of life for people. Thank you so much for providing this opportunity. It was a great learning and also a help for us also. Thank you so much.
Thank you, Dr. Kavita, for that very elaborate description of the health technology assessment initiatives in India. And participants, if you have questions, please type them in the chat menu. We will take the questions at the end of all the presentations. And for the public health and community medicine postgraduates and their faculty, I suggest that you please remember to include at least 2 to 3 sections on health technology assessment in India, what are all going on, because for upcoming public health professionals, actually it will be a good area to get accustomed to. It's very, very important. You can contact Dr. Kavita or any of the resource hubs, and almost every state has a unit on health technology assessment in India. And please ensure that your students are or students are familiar with the health technology assessment India initiatives. Now we will move on to our second speaker, Dr. Shankar Prinja. So probably Dr. Shankar Prinja is the pioneer of, I would say that he's the lead person of health technology assessment in India. And he's right now is a professor in Postgraduate Institute of Medical Education and Research, Chandigarh, and he's having more than 15 years of experience. And yeah, his significant contribution in economics and cost effectiveness analysis, and they do conduct an online training program on cost effectiveness and equity analysis and healthcare financing. More than that, he is quite pivotal in charting out many of the evidence synthesis, which are prerequisite for taking up health technology assessment in India. Now over to Dr. Shankar Prinja.
Thank you, Dr. Biju. I'll try to share my screen and let me know when you can see my slides in the full view.
Yes, we can see. You can go ahead.
All right. Thank you so much. And thank you to the organizers for having invited me. So as Dr. Kavita has already given a very elaborate background on the establishment of HTA systems in India, I'll try and particularly focus my talk on specifically on trying to identify that what are the potential linkages between HTA and the rollout of the Ayushman Bharat PMJY scheme. And I'll try as much as possible to give some illustrations as well and use some case studies in order to say that which are those areas where HTA could be used for decision making in the broader context of resource allocation for Ayushman Bharat PMJY. So the conclusion or the 4 broad areas that I would eventually recommend as you go through my slides are 4. There are 4 broad applications that I would suggest that where HTA evidence could fill in for PMJY decision making. The first is that it can help in determining that what goes in and out of the benefit package. So PMJY is a large scheme which provides health insurance. It has more than 1,500 health benefit packages. So which means that, for example, one health benefit package is for PTCA, which is for coronary angioplasty. The other could be for CABG. There could be another health benefit package, which is for, let's say, treatment of breast cancer using radiotherapy. So these are different health benefit packages or interventions that have been identified. So which interventions should be part of the overall health benefit package is something that HTA can guide based on evidence for cost effectiveness. The second is that while you may decide that there is a given health benefit package, so for example, you may say that there is the cancer, radiotherapy for cancer is a health benefit package. But within providing radiotherapy for treatment of cancer, which is the best modality in terms of the value for money? Is it the two-dimensional cobalt radiation, or is it the intensity modulated radiotherapy, or is it the more advanced forms of delivering radiotherapy, which is IGRT? So that's the second application, that within a given health benefit package, what should be the technology that should be used? What should be the way in which the treatment should be provided as part of the health benefit package is something that HTA evidence could support. The third important application is that there are standard treatment guidelines that are being framed for each of these health benefit packages. That means how should the healthcare providers be treating a given patient of a given health condition. And this standard treatment guidelines are being framed because there is such heterogeneity in the provision of healthcare services. So there is a rationale for trying to suggest which is the most optimal way of treating a given person with a given health condition. And so, for example, the case study that I'll be using is treatment of breast cancer for using a given drug, which is called trastuzumab. Now, there are varying guidelines that this drug could be used for 3 months, could be used for 6 months, could be used for an entire 1 year as well. So how long a duration of the use of this drug should be recommended and should be funded under the PMJY program is something that, again, HTA evidence could guide. And finally, the fourth application is that having decided that, okay, this is the health benefit package that could become part of your overall benefit package. This is the technology that you should be using. This is the standard treatment guideline. The ultimate question is, what should be the price at which you should be delivering this? Or what is the price at which you should be paying your providers to deliver that health benefit package? That's the fourth the sort of recommendation or application area that I would identify. And then I'll now try and use some case studies in order to illustrate the points that I've made in my opening slide. Now, this is the first case study that I'm using. For example, there is a code within the PMJY benefit package, which is MO001F. This code is a health benefit package, which is basically for treatment of non-metastatic breast cancer and the treatment that is to be offered with adjuvant trastuzumab. This is one of the drugs that is used for treatment. Now, the decision problem is, A, what should be the duration of the therapy? And B, what should be the price? So at what price should you be paying providers in order to deliver this treatment? Now, the duration of the therapy could range from 1 year to 6 months to even as low as 12 weeks. And the problem is that different guidelines recommend different, treatment durations. So, for example, we have an ICMR guideline, which says that 1 year use of trastuzumab is the standard, and they cite the international guidelines as the reason for giving this recommendation. But it also says that 9 to 12 weeks is also an acceptable alternative. Similarly, the National Cancer Grid, it gives certain recommendations for different stages, but it doesn't really give a recommendation on the duration of the therapy. And the PMJY, it says that 12 weeks is what is recommended, as well as 6 months also it says it is recommended. So basically it says both 3 or 6 months are acceptable, but 1 year, which is actually recommended in the ICMR guidelines for treatment of breast cancer, is not something that the PMJY pays for. So that's the question or the decision problem. Now, we did a study in order to determine that what is the cost effectiveness of use of this drug trastuzumab for treatment of breast cancer. And as you can see that there are 3 different options that we explored, either 1 year or 6 months or 9 weeks use of the drug. And ultimately we computed a probability for the drug to be cost effective at the current level of threshold for either of these 3 treatment options. And what we find is that the 1 year treatment option has a very low probability of being cost effective. The variation is from about 4 to 57%. The 6 month and the 9 week trastuzumab use has a very reasonably high probability of being cost effective, almost like 90% in 6 months and 100% probability of 100% sure that it is going to be cost effective if you give it for 9 weeks. So what it means is that if this evidence on HT is to be used, then this either 12 weeks or 9 to 12 weeks or 6 months, what is being currently recommended under the PMJY should be the treatment of choice. But then if 1 year treatment is to be allowed, then we know that it is not currently cost effective, but could there be a reduction in price of the drug that could make it cost effective? So here, what we show here is that if this is the base price, if this is the price at which the drug is currently being marketed or procured in the public system, then the probability for it to be cost effective, which is shown on the y-axis, varies from about 4% to about 57%. But if you lower the price of the drug through any mechanism, either offering bulk orders or by negotiation of the prices, etc., and if you're able to lower the price to about 35% of what it is, then even a 1 year trastuzumab becomes cost effective. And you see that this base price is also something that the National Pharmaceutical Pricing Authority has regulated the price at this level. So what it means is that even at this regulated price, the drug is not cost effective for use up to a duration of 1 year. But if you're still able to lower the price further by almost 1/3 as against the regulated price, then it may become cost effective and it could be recommended. So what I'm trying to illustrate here in this slide is that HTA evidence could become a guiding tool for decisions around pricing, price negotiation, and price regulation as well. The second case study, again, I'm using, again, in the context of cancer itself. And this is the same type of cancer that I showed earlier, which is breast cancer. There's another health benefit package, which is specifically for the delivery of radiotherapy in post-mastectomy breast cancer patients. But the decision problem is that which technology should be used? And there are different options. Either you use 2-dimensional radiotherapy, 3D CRT, or IMRT. How much should be the dose that should be given to the patient? Should it be 40, 45, or 50 gray? How long should it be given? Should it be a 3-week or a 5-week duration? And what should be the patient subgroup in which radiotherapy should be offered? And the patient subgroup could be classified based on the level of involvement of the lymph nodes. So again, we did some, and there are guidelines do not make very specific recommendation on this particular issue. So for example, we have 2 guidelines for treatment, ICMR and the PMJY standard treatment guidelines. They give you options of treatment with a variety of different possible combinations in terms of dose, in terms of fractions, and in terms of the duration. And ultimately, it leaves to the clinician or the oncologist to prescribe whichever guideline treatment methodology that it would like to offer. But this doesn't solve the problem because maybe some of these recommended options may not be very cost effective. So we did some analysis around this issue. And what we found was that among patients who do not have a lymph node involvement, radiotherapy treatment is not cost effective at all. Among those who have lymph node involvement, either 1 to 3 or more than 4 lymph node involved, the radiotherapy is cost effective, but the one that is the most cost effective is the 42.5 gray application using 2DRT, two-dimensional radiotherapy technology, that means cobalt radiation, for a duration of 3 weeks. So this turns out to be the most cost-effective mechanism of treating breast cancer patients with radiotherapy. So this is how the guideline could be further refined and modified such that you are able to draw the best value for the money that is being spent under the PMJY. But as Dr. Kavita also mentioned in her presentation, that evidence on cost effectiveness may not necessarily be the only criteria based on which decisions could be made. And there could be other criteria as well. For example, equity. How much does a new intervention or a drug or a technology improves the equity in utilization of healthcare services? Does it improve the access to the ones who are the most vulnerable? Or how much is the potential of reducing out-of-pocket expenditures for people who are to access care? Or there could be issues around feasibility and acceptability. And finally, there could be an issue around the budget constraint also. So there could be a range of other considerations also that could play an important role in making decisions around health benefit packages. So we did some work around trying to suggest a framework for designing health benefit packages for large insurance programs like PMJY. And one of the approaches that we tried suggesting as part of the framework was that, if you have different possible scenarios for packages with coverage of different types of diseases, what is the potential that each of this package is likely to bring about a reduction in out-of-pocket expenditure? So what we show here on the right side is for the poorest 40% of the population, if you go on with status quo, that means you don't have an insurance, then this is the average out-of-pocket expenditure that a family has to incur on healthcare. And this is the level of impoverishment as a result of healthcare expenditures that people face. With each successive expanding package of conditions that you could create or develop, there is a certain reduction in the out-of-pocket expenditure. So for example, in the scenario 2, where you have coverage for certain diseases, there is a reduction in out-of-pocket expenditure of about 31%. If you increase the coverage, include more other NCDs and other non-communicable diseases also besides CVD, respiratory infection, injury, and neoplasm, you can reduce the out-of-pocket expenditure by 70%, and you can reduce the extent, the relative reduction in impoverishment would be more than half. And similarly, if you can make it even more comprehensive by including some of the RMNCH services as well, then you are able to reduce the expenditures by close to about 90% and impoverishment by about 80% on a relative scale. So this is how, again, evidence could help inform decision-making for designing health benefit packages. And you may have also decisions to be considered around what should be the height of the benefit package. So when you consider the UHC cube, the height of the cube represents that how much should people pay for, or in other words, how much does the insurance company or the insurance scheme cover? And there could be different levels of coverage. The current PMJY is even more than the 3 lakh coverage, which is about 5 lakh. But you can see that for each of the different levels of coverage, there is different potential of reducing out-of-pocket expenditure as well as impoverishment. So again, such evidence could help inform decisions around framing health benefit packages. And then, as Dr. Kavita was also mentioning, that one of the decisions that needs to be taken in the context of such a program is around pricing. And she did mention about a large costing study that is being undertaken. And this costing study has led to the revision in prices of the PMJY scheme. And here on the right side, I show you the snapshot of the paper that we published, which documents the process of price setting using the evidence on cost from the CHSI study. But then another important consideration is that you just don't only rely on evidence on cost effectiveness, but you also need to see that how much of impact does such expansion or scale up have on the budgets of the program. So we tried doing some analysis around fiscal space. That means how much impact would it have on the budget when you scale up the health and wellness centers. And this is the second pillar of the Ayushman Bharat. So we tried showing from different years, from starting from 2019 to 2023, as you scale up the number of your sub-centers and primary health centers to become health and wellness centers. And in all, we want to scale up 150,000 facilities as health and wellness centers. This is the amount of increase in the relative increase in the budget that you require each year in order to meet such scale-up requirements. So the first year you'll need the overall budget to increase by at least 2.5%. Next year, nearly 5.5%. Next year, 7.5%, 10%, and then about 12% relative to the previous year. So this is to give a sense to the policymakers that how much extra do they need to spend if they need to embark on such ambitious scale-up promises. I'll give you another example from not from India, but from another country, which is Lao PDR, where we tried supporting the evidence on how much does it cost in order to scale up the services. And there was in this country, they had developed an essential health package, that the government committed to provide free of cost to all citizens in the country. And the question then was that what is the cost of delivering this package, and is there enough capacity, fiscal capacity, to fund this kind of a scale up? And what we found in that country setting was that from 2019 to 2025, if you want to achieve the scale up to provide coverage of all essential services that is being promised, then the amount of allocation needs to go up by about 3 times, from about nearly $78 million to about nearly $250 million. So that's like a 3 times jump in the overall allocation. And we then also tried stratifying this increase in the level of cost by the type of different health conditions and by the level by the level of healthcare delivery where you would need to incur this cost. So this is again to emphasize that where is it that you need to spend more and at what level do you need to spend more. But then there could be a question that, okay, this is what we need to spend, but do we have enough capacity? And that's a big question. So we did this sub-analysis in the context only for immunization, where we tried showing that, if you want to achieve the aspirations of your vaccination, including both traditional and the newer vaccines, then this is how much you should be spending every year. And this is the per infant immunization cost. This lower red line represents that if you were to only spend on traditional vaccines. And this is the actual what we can forecast given the current allocations on healthcare for immunization. So what this shows is that given the current allocations of the government, the current government allocations would be sufficient to meet the traditional vaccinations, but there would be a significant gap to fill in if we were also to introduce the newer vaccine. And why this piece of analysis becomes important is because immunization is heavily donor funded in this particular country. And the question was that the donor was about to leave. So Gavi was the primary donor in this country context, and Gavi was about to phase out. So based on this evidence, there was a decision taken that Gavi needs to prolong the exit strategy from Lao PDR. And so it needs to continue funding the immunization program for some more years so that the country is able to sort of increase the overall allocation for immunization, which cannot happen overnight. This is my last slide, where I'm trying to just say that although we are trying to say that HTA is absolutely necessary for decision making and policy making, but there are a number of implementation challenges as well. The challenges include building human resource capacity, and there are steps being taken in order to address each of these challenges as well. For example, as Dr. Biju Soman was also mentioning, there are a number of workshops for building capacity of the healthcare personnel that is being undertaken by the DHR. There is also this user perception. When you ask the clinicians that we have framed a standard treatment guidelines on the basis of cost effectiveness, and you have to now adhere to this guideline, this sort of, it constrains them in terms of their clinical practice, because they don't feel sort of liberated to make decisions as per their own judgment. And this becomes a big, obstacle in trying to convince that this is something that is necessary, on the grounds that you are able to free resources for making sure that you are able to offer treatment to a large majority of the people. So this user perception needs to be corrected. This needs to be corrected through a larger stakeholder consultation. There are other issues also that the DHR is trying to address to improve to correct these challenges. For example, there are a number of guidelines that Dr. Kavita had shown in order to improve the consistency in processes of undertaking. There was also a lot of information shown by Dr. Kavita on building of databases to improve the availability of data and to have high quality data that could be used in such analysis. But there's a final governance challenge that still remains in the context of a large, relatively unregulated private sector that exists in our country. But there is an option now with PMJY coming in and becoming a single largest purchaser of healthcare services. There is an opportunity that there could be some degree of governance for this large unregulated private sector. Thank you very much.
Thank you, Dr. Prinja, for that very informative presentation. Actually, Dr. Prinja has given us, he has walked us through the process of HTA to some extent, actually, by giving examples from this transfusamide and radiotherapy after mastectomy, and its examples from LAVO PDR and all. So you might have noticed that for undertaking an effective health technology assessment, we need expertise on that domain, and then we should have a capacity to do cost analysis, how to do a costing of the health intervention, and how to assess the health impact. And now we should be very thorough with systematic reviews and meta-analysis, and we should be very familiar with the HTA framework. And these all things should be done in a time manner, so that of course there'll be some policy windows coming up, and policy windows are very brief, and we have to give answers to the policymakers in layman terms. So although we are doing very, very complicated scientific analysis in the background, and which should be shared with our peers and academic colleagues, but for the policy persons, actually, we have to give it in very brief policy briefs in layman's terms. That's a challenge. And I'm sure that there will be many questions on that. We'll take the questions after we hear from Dr. Beena Joshi also. Thank you, Dr. Prinja, for the timing. Please stay for the Q&A session. Now, can we have Dr. Beena Joshi? Actually, like Dr. Prinja and Dr. Kavita has mentioned, when we look at the cost effectiveness thing, actually, which are the areas where we have to focus on? And maternal health is definitely one of the sought after health need in our country, and how far we can bring in some empirical evidence to come up with pragmatic solutions in the area. Actually, that's one of the areas which Dr. Beena Joshi will be delving on. And she's a scientist in the NRI of ICMR Mumbai, and she's having 25 years of experience, and she got many awards like Golden Jubilee Research Award in 1916, International Fellowship in 1916-17, and a travel grant for a Global Maternal and Child Health Conference. And she was the best oral presentation. She got the best oral presentation award for the paper Community-Based Prevalence of PCOS Phenotype among Young Children in Mumbai at the Androgen Access and the POS Society Update meeting. And she is having many publications to her credit. And can I request Dr. Beena Joshi for her presentation?
Thank you, Dr. Biju. Can I share my screen?
Please.
Is it visible?
Yes, you can change over to the slideshow? Yeah, fine. Please go ahead.
So good afternoon, everybody. At the outset, I would like to thank the organizers, especially Dr. Sitanshu, chairpersons of this plenary, and of course, Dr. Prinja for inviting me to be part of this plenary. I'm indeed very happy to be part of this HTA family. Thanks, Dr. Kavita and the whole DHR team. And Dr. Sitanshu, Dr. Biju Soman, we are all co-travelers in this journey, and I'm very happy to be part of this entire family. So my presentation today would focus on cost effectiveness interventions to improve maternal health in India. So what I'm going to do is take you through a few of the studies that we have done. I was a very recently established HTA resource hub. And so we have undertaken a few studies, but also I will focus on some other studies that have been there in the literature and take an overall view of how decisions are made and what needs to be done ahead to improve maternal health in India. So we all know we have these SDG targets, especially focusing on maternal and neonatal health. And we are still a lot of way behind to achieve these targets. The bold ones are what we stand off as of today. And we have to reach those targets by 2030. And of course, the out-of-pocket expenditure on health also we have to reduce. And Dr. Prinja alluded to some of the strategies that issues have been taken up at large scale. To achieve these targets, it is very important to strengthen what already exists and to improve access to quality care. But also, we should know that reaching the last few miles is the most difficult. So the low-hanging fruits are easy to achieve, and I think we have done a great deal in that. But we need to rethink our strategies, bring in new interventions and programs to achieve that last mile. And so whatever effective interventions are there in order to bring it into the program, cost effectiveness will be, of course, an important measure. So as I mentioned, our resource hub was set up in 2018, and HTA and DHR has done a lot of hand-holding, capacity building, and they have given us a lot of manpower who have been trained. So our primary mandate is to sensitize the state governments and stakeholders. And we have also been educating a lot of students from MD community medicine residents and postgraduates on what is HTA, because as Dr. Soman mentioned, it is I think Dr. Sitanshu mentioned, it is a very upcoming field and we have to enthuse new minds into this. So now coming to the first topic, which was on etonogestrel implant. So this was it is a new contraceptive implant, still not being launched through the National Family Planning Program. And the question came to DHR whether it is a cost-effective option to be introduced into the basket of choice of existing contraceptives in our country. ICMR had done a very large-scale study in this regard, and we had almost enrolled 3,000 and odd participants, and it had shown a great effectiveness with a very few loss to follow-up and side effects. So it was indeed something that was worth investing, but then the Family Welfare Division asked DHR whether it is a cost-effective intervention. And so the question was routed to our institute, being the mandate, reproductive health. So the question that we took up was the intervention of Implanon, as it was called earlier. Now it is Nexplanon, which is a 68 mg etonogestrel implant with a radio-opaque dye in it. Whether adding this to the existing basket of choice is a cost-effective intervention compared to the existing package, which is all the other contraceptives that are already there in the program. We followed the approach that has been outlined in the HTI and reference manual. So all our studies look at societal perspective. We also try to do the systematic review and meta-analysis to ascertain the effectiveness of the intervention, and then also do primary costing if it is not available. And we look at the literature to assess the, to find out the quality of life measures, the utility score, scores and then build in the model. For this particular exercise, the economic evaluation was based on the Markov model. And through the Markov model, we were able to demonstrate that it is indeed a very cost-effective intervention, because the incremental cost utility ratio, which is difference in the quality gained by the difference in cost by difference in outcomes, was about 16,873 per quality gained, which is well below the threshold of 1 times GDP per capita. And the budget impact analysis also demonstrated that it would need only less than 1% of the total annual health budget to bring this into the program. So in course of our exercise, we could also bring out the package cost of providing various contraceptives from the health system perspective. And this result was shared with the ministry through this policy brief, and we have published a lot of 4 papers on this, on the cost effectiveness as well as the cost and systematic review. The next question that was posed to us was from the maternal health division. As you all know, postpartum hemorrhage with a prevalence of about 6 to 7% in all deliveries is one of the major causes of maternal deaths in India. And the policy question was about uterine balloon tamponades, which is mainly used to manage atonic BPH. So this is already a part of our guideline that uterine balloon tamponade is one of the very effective measures to control postpartum hemorrhage. And even WHO has recommended it with some caveats that you should have a backup of surgical procedures wherever needed. But in a country like ours, we know that referral is one of our key, we don't have all those surgical procedures at the primary healthcare level. And so it becomes very effective for transport, or we can buy time if this is an effective measure. So condom UBT is one that is recommended and it is available in the program. But there are other uterine balloon tamponades such as the Bakri balloon, which is commercially available. And government was specifically interested in the this ESM UBT, which is every seconds matter UBT, which was developed by MIT USA, and it has been an FDA approved product. So they were keen to know, and some pilot studies were done in India, especially in Maharashtra, on this UBT, and they had found it was very effective, and they wanted to try out and bring this into the program because it comes in a sterile package and it has good tensile strength. It is a condom itself, but with different material, and so it has a better tensile strength to withhold the fluid. So we looked at all the available literature and the systematic review that we did, that we found very poor evidence available for the ESM UBT because there were only case series or case studies, and there was no large RCT done on this particular device, and so the quality of evidence was very poor. However, since the maternal health division was interested, we went ahead to take this intervention ahead. We also looked at all the costing that was needed for bringing this into the intervention. So this particular study revealed that ESM UBT is cost saving with a ISER of -2412 INR per DALY averted, but it had an error probability of 0.36. And ESM UBT yields a base case positive incremental net benefit, net monetary benefit compared to condom UBT. But we did not recommend this for future scaling up because of the poor quality of evidence. And we did recommend that robust comparative study is needed to see the effectiveness of this particular UBT compared to the existing UBTs in India. So these are the publications. And the third study that we did was on use of tranexamic acid in management of BPH in India. So IV tranexamic acid 1 gram is recommended for atonic BPH in India, but WHO does recommend it for all causes of BPH, and a large woman trial was undertaken. Of course, India was not part of it, but then this question was posed to us by the state government, whether tranexamic acid should be part of the Lakshya guidelines and the important emergency medicines that are available as part of the emergency tray in the labor room. Currently, it is not part of that package. So whether tranexamic acid should be used for all cases of BPH, it was the question that was posed to us by this state government, and hence we undertook this study. We did use the economic evaluation decision tree model, and the ICER values that we found were 1,470 per quali gained. Of course, we could demonstrate that a lot of deaths were prevented, maternal deaths were prevented, and qualis gained, and also net health and net monetary benefits were very obvious. And so the recommendation is to add TXA to the existing package of services that are dealing with the BPH. And of course, there is a very strict guideline that it has to be used within 3 hours of delivery for all cases of BPH, after ruling out any other cause in terms of tear or retained placenta, etc. This study was recently approved by the Technical Advisory Committee, and we would soon be giving the inputs to the state government to go ahead with this particular intervention. So we have a couple of other studies that are ongoing, looking at different prongs of parent-to-child transmission to look at which is the most cost-effective intervention to reduce unintended pregnancies among PLHIV, because we have a target to achieve 0% HIV incidence rate, and still a lot of programs are, the HIV programs are not addressing the unmet need for contraception among these population. And so is it because they are very happy with the new regimen that has been available, option B plus, to prevent mother-to-child transmission once the woman gets pregnant. But is it more cost effective to prevent the unintended pregnancy than the option B plus regimen is what we are looking at. We also recently have got a study funded through DHR, and we are trying to look at this IV iron sucrose versus the IV pericarboxymaltose, its cost effectiveness in treating anemia in iron deficiency anemia in pregnancy. And there are a couple of other studies that we are going to plan. So these are few published studies in literature where we can see that before a lot of interventions on HIV came into the program, good studies were done to demonstrate that these were in fact cost effective. So the pilot testing of HIV screening program, integrating it into the primary healthcare and antenatal services in Maharashtra, this is a published research, and which demonstrated that an addition of 27% of HIV infected women could be detected, and of course the incremental cost effectiveness ratio was very low and per woman tested. The other study was on cost effectiveness of childbirth strategies to prevent mother-to-child transmission, and again vaginal delivery, because there was a lot of fear of vaginal delivery causing the transmission, and most people were opting for cesarean section. And so this study also demonstrated that vaginal delivery was not only cheaper, but also if we give nevirapine, it was a cost-effective intervention. Study by Dr. Prinja on a M-Health intervention by community health workers to reduce maternal and newborn mortality demonstrated that it does reduce maternal and neonatal deaths, and it is in fact a cost-saving intervention from the societal perspective. This was a very interesting study published by Sue Goldie et al. And they looked at alternative strategies to reduce maternal mortality, and family planning intervention came out to be the most cost effective to reduce pregnancy and related mortality. So if unmet needs of contraception are met, they worked out in terms of how many maternal deaths could be averted and how many billions could be saved even if you averted abortions or pregnancies in this age group. I came across this very interesting article. It was a WHO choice analysis recently published in International Journal of Health Policy Management. They have looked at cost effectiveness of interventions to improve maternal, newborn and child health outcomes in sub-Saharan Africa and Southeast Asia. So it is a very large scale analysis, and it examines cost and impact of MNCH interventions in these two divisions. What they used was the general cost effectiveness analysis, and they came out with average cost effectiveness ratios. They used the 2010 epidemiology, and the cost and global disease burden of these countries were used. And the study evaluated 16 interventions and 6 packages related to MNCH, which are promoted by WHO, which are recommended by WHO to be used. And they evaluated the coverage, if coverage is at 50%, 80% or 95%, how cost effective it is. So what they did was they looked at the interventions and compared to a hypothesis of a null scenario. If there is no such intervention, what happens? The health impact was measured in health life years, and the costs were calculated, and the differences were scaled up between scale up and null. The costs were from the health system perspective, and they were reported in international dollars. The costs and impacts were assessed over 100-year time frame, and the average cost effectiveness ratios were calculated after accounting for discounting and also sensitivity analysis. So their threshold, I would say, most interventions, if they wanted to say if they were cost effective, they had a margin of 100 US international dollars per health life years gained. And so all the interventions that looked at skill delivery, management of complications, family planning, preventing unintended pregnancies, managing unintended pregnancies in terms of abortion, safe abortion, not only provision of abortion, but also post-abortion care and contraception. And also the third most important intervention was on nutrition, balanced protein energy diet to reduce risk of stillbirths and neonates. So we know that definitely these are very important interventions to prevent maternal mortalities and reduce all the morbidities among these very vulnerable population. And so this is a very clear picture that without doing any much studies, existing interventions are cost effective, definitely, and they need to be re-emphasized. At all community levels, these interventions were far below international dollar of 100, and so they were very cost effective. So the results also showed that pregnancy and childbirth interventions had a median ACR of 27.4, which was very low. And access to contraceptives stand out as a high value for money investment. Integrated packages were more cost effective than the single procedure, single interventions. And sensitivity analysis for discounting and cost variation did not affect the rank in order of the interventions. So to conclude from all the available literature, the studies that we have done, cost-effective interventions do improve maternal health outcomes, and these must be emphasized for more resource allocation, for priority setting and inclusion for universal health coverage. However, we cannot ignore improved access, quality of clinical care, and multi-sectoral engagement, which are very, very crucial. But I feel HTIN, Dr. Kavita is working very hard. We have to advocate its role and facilitate policy decision making based on cost effectiveness results, because this will be very crucial to meet the SDG targets to bring in more cost-effective interventions into the gamut of available interventions, and of course, as I mentioned, strengthen the existing interventions. So this is my team at HDI and HDA Resource Hub at NIRRH, Dr. Kusum, Siddesh, Himanshu, Revati. They have done all this work, and thank you to one and all. With this, I end my talk, and I would be happy to answer any questions, if any. Thank you.
Thank you, Dr. Joshi. And Madam has given us an elaborate, very informative presentation on the HTA applications in reproductive health, and she has given some examples of nexplanolone, uterine balloon tamponade, and tranexamic acid in the control and the management of PPH and all. In her presentation, she emphasized the importance of quality research, and that is very, very important. So whatever research we take up as postgraduate students or as faculty members, actually, they should have the quality. When we are doing systematic analysis, looking for evidence, if we have very good studies, actually they will be included. If the study lacks any sort of the quality parameters, if they're not conforming to consort guidelines and other than study, we may have to discard those studies. So almost every aspect of our community medicine or public health competency is needed for taking this HTA forward. I'm not seeing any questions from the chat box, but we have 5 minutes, and so I'm opening this for discussion. And can I ask a question to Dr. Kavita? Like, ma'am, I know that you are doing a very excellent work, but this health being a state subject, and how far you are getting the buy-in from all the states and union territories on adopting the guidelines put forward by DHR?
So I think a very, very good question. The point is that, yes, health being a state subject, I think Dr. Shankar Prinja also said that the implementation challenges are very high for us. And the user department doesn't understand what kind of topic can be taken up for HTA. It cannot be randomly, every particular research cannot be taken up for this. So bridging up this gap of the state government understanding. So for this only, we have nodal officers who have been identified in the state government. We are also having state sensitization workshops to make them understand what kind of topics can be provided for undertaking HTA studies and how they can be implemented. The major drawback in the studies not being implemented has driven us for this preparation of a legislative board, because a documented legislative board will automatically make it, even though it will be an advisory, it will be slowly we will be able to scale up and go into a statutory mode also.
Thank you, ma'am. Thank you, ma'am. And Dr. Shankar Prinja, you were bold enough to explore this area of health technology assessment and health economics. Probably you are one of the pioneers of this HTA initiative in India. So, what's your advice to the budding public health professionals?
So, I think that with this platform that Dr. Sitanshu has provided us, we would definitely like to encourage a lot of our young students and young professionals in the fraternity that this is an area that is fast becoming very important, especially given the kind of reforms that are taking place within our health system around financing, around provisioning of healthcare services. Majority of the, a lot of times I tell my students that, specifically when you go to a primary health center or a district hospital, or if you're a manager at the district level, let's say, the one indicator that you're always bombarded with and where your performance is always monitored upon is basically coverage of services. That's the only thing that, civil surgeon will ask his program officer will ask the CHC block medical officer, etc. And coverage of services, if you look at, is nothing but a play of demand and supply side characteristics of healthcare services. And so public health professionals who are managing the health services, health facilities, should definitely be aware of trying to address the determinants of utilization of healthcare services, both on the demand side and supply side. And this is something that comes through application of a lot of economic principles as well. And when you look at a lot of healthcare interventions that the government is also trying to put in, implicitly they may look like very routine kind of healthcare interventions. But if you look at the bottom line of these healthcare interventions, there are principles, economic principles that are fundamentally linked to them. Whether you talk of things like, let's say, conditional cash transfers like Janani Suraksha Yojana, or making things free of cost such as JSSK or others, where basically the intervention may look like something that you are trying to influence the, make things free for people, but ultimately your intent is to influence the price at the point of care for people to access health services. And basically, you're trying to influence the demand through your intervention at the point of pricing of the healthcare services. And then the whole range of interventions around demand side financing through introduction of these publicly financed insurance schemes. These are all things which are only possible to be implemented in the right manner if you have the right knowledge and skills in order to sort of implement these programs. So to all the young professionals and students of MD community medicine and young professionals who are listening, I think definitely in your public health career as well, you need to understand these basic principles of economics that need to be applied in the field of healthcare. Thank you.
Thank you, Dr. Princha. And now, Beena Joshi, madam. So, how can we have buy-in from gynecologists and those practitioners, especially specialists for this protocol-based management?
Yeah, so after this HTA interventions and the studies, the standard treatment guidelines is something that will feed to making the standard treatment guidelines. And I think through this, advocacy will be very important through various committees like FOXI or any other professional committees to take this ahead. And of course, it is a challenge. In private sector, there is no control of the way the things are managed. We don't have a control, but at least in public health system, we can ensure that it can be done in a systematic manner, is what I say. Thank you.
Thank you, ma'am. Thank you, ma'am. And Dr. Princha, you have something to add?
Yeah, just on the point that Dr. Beena mentioned, I mean, in order to encourage the clinicians to or to bring them into the fold, it is going to be a Herculean task. But I do see that schemes like PMJY basically are trying to create a single large purchaser. The fact that clinicians are averse to any kind of regulation is because we live in a multi-payer system where each patient comes in and there is an interaction at the level of healthcare delivery for each patient and the doctor. But in the context of these insurance programs, this is the single large purchaser that is now procuring on behalf of all the patients or the community. And that offers a bit of a leverage to the government to some extent bring in the clinicians also within the fold of regulation and to adhere to the standard treatment guidelines, etc.
Thank you, Dr. Princha. And due to lack of time, probably we have to wind up this discussion. And let me take an opportunity to thank all the expert panelists, Dr. Kavita Rajashekar, Dr. Shankar Princha, and Dr. Beena Joshi. And let me thank the organizers, especially Dr. Sudhanshu, for giving us this forum to discuss on HTA. Thank you. Over to Dr. Sudhanshu.
Thank you, Dr. Biju. It was really a wonderful session. The purpose of having this session in this platform is exactly what Dr. Shankar told. It is our responsibility to build a cadre of a group of specialists who can talk about the numbers, who can discuss the numbers at ease with the policymakers and the return on investment and all the economic questions that people usually ask while making a decision. So we have a responsibility and we have a greater role to play in our curriculum to include all these things, and probably such platforms can be utilized subsequently to also educate and sensitize our students to take HTA very, very seriously. Because whenever we talk about economics, health economics, people think it is beyond our scope. In the boundaries are not there. But as a public health professional, when we have to do advocacy, when we have to talk with policymakers, it is an important skill to have. And that's why we had to have this session. I'm so thankful that everybody chipped in. They contributed and in planning of this session, and special thanks to Dr. Shankar. In the night 10:30, he has to discuss the plan and let me know how it should go. And you know that he is extremely busy preparing for his APS. But I'm so thankful to Dr. Shankar. Dr. Kavita, always supportive, always very, very supportive of any activity that we would like to have. And Dr. Beena, we will start working on something together. That is how we build the friendship and collaboration. And Dr. Biju is always there at one arm's length whenever we want something, then he's always there. Thank you so much. On the behalf of the organizing team, I take this opportunity to thank you once again. I hope the number of the people who have logged in for this session will find this useful. We are going to make a repository of this teaching, whatever we have got here, and it will be available for public use for academic purpose. We are not doing it for something else. So with that, I take your consent for that as well, if it is not very, very difficult, because this is all, everything is there in public domain. So that's why it is. So with that, I close the session. Thank you once again. Thank you so much.
Thank you very much, Dr. Sitanshu.
Thank you.